Thế nào em? Thế nào?
First case.
We Dr. Mission, maybe you want to wait the Naila or it start?
No. I think we should start.
She's in the.
Yes, she has to stay there.
Yeah. Maybe we can start.
Yes, we can start. I'm sorry, Dr. Whom is here, so we can start.
Gửi cái slide rồi khi thôi chị đọc máy.
Reload Internet Explorer.
Cái gì ạ?
Reload Internet Explorer.
Anh ơi, không, anh cứ đăng nhập đi, xong rồi anh sẽ mở ở trên này có Infinite đúng không ạ? Mấy cái này của em có
Nó phải
đúng rồi, trên này em có thấy Infinite đâu?
ở trên này không có cái gì đâu.
Vâng, cái này có đâu? Thấy đâu? Thế thì vào đúng rồi, mà trên kia không có nào. Có được.
Chức năng bật cho mấy kia.
Trời.
Yes, you can see.
Cái màn hình bên này em thấy có Infinite. Tình hình này em. Alo. Thế thì nhờ ai đi đưa bà lên nhé. Alo. Chị có chuyên gia với cả mấy bạn ở Huế thôi. Chị đâu cùng ăn. Giờ chị đi. Đây đang trường đang em ở đây rồi, trường đây là đây trường đây
Nếu mà dài chị không
Recording stopped.
được chưa? Cũng là bị thế nhiên là được thì đi qua cái cực như vậy kia bên kia cũng là dạng được rồi đến mà tình lão thoát rồi tình nào đến mà em thì tình biết
Tuấn à?
vậy phải còn ba được sức
Troisième semestre, tu as eu
không được. Mọi khi vẫn dùng được cơ mà nhỉ?
một lần nữa nào được trở lên.
Alo. Chị bảo này, chiều nay bọn em có online với cả cái hội trần của viện Nhi này không? Tại vì là chắc là cái khoảng độ ca cuối cùng ấy bọn chị có hội trần ca mà tầng Vinh mà ở U Linh Phô Bắc Kim mà không biết bạn nào bảo là nội chú của nhà em nên đăng kê nó đấy, đơn gửi cho hội trần của chị đấy, thì tí nữa với ca tầm độ chị không nhớ tên bạn ấy, rồi bạn nhắn cho chị thì chị quên, bây giờ chị không biết tên bạn là gì để tìm. Chắc là ca cuối cùng chắc phải tầm 4 giờ hoặc là không thì nhưng mà em soi với động em phải vào đăng ký với link bọn chị đi tìm mới vào được cái link mà echo mọi gửi trên nhóm bác sĩ em có vào trong nhóm đấy không? Đấy thì sáng nay bọn chị cái link em vào link thì lúc nào đến người ta đấy bọn em nghe nhá. Đấy nhá.
Có ra cái đăng nhập. Nhập xong có ra
scan chủ yếu.
Có 2 ô trong túi. Đây để gọi. Đây để gọi.
Nous, vous êtes sur le fait de comme on a lâché cette
đây, nó chia làm 2 năm này, là đăng nhập vào phòng rồi.
Cái đó có phải ra một cái ấy cơ, có phải ra một cái giao diện cơ. Bây giờ đăng nhập vào đây rồi lại trọng phơi nhé.
Bây giờ
dùng máy nào, chứ mà dùng máy nào anh? Hay dùng máy đấy?
Dùng cả 2 máy này đều chạy được cái
em biết, nhưng mà đây em đang hỏi chứ không dùng máy nào, máy này bây giờ hiện tại vào được rồi. Chẳng tính này thì chẳng vào.
con laptop này 2 máy luôn. Đây chạy đang Flash Explorer.
Nhưng mà ra trọng nên nó không được anh.
Thế bây giờ làm cái
Tổng buổi
có dùng vào hôm mùng 3, mùng 5, mùng 6, mùng 7 cả ngày cả. Chị đã này, công nghệ thông tin họ báo cần phải setup báo trước cho họ setup máy nữa. Còn luôn này thì họ cũng làm luôn hơn.
Thế thì bây giờ em bảo họ set up này để ngày thứ Tư được, còn bây giờ chị lại cái kéo quân xuống dưới, một là xuống tầng 3 hay là xuống
tức là nhờ họ làm từ 5 đến
tức là thứ 5 thì rồi thứ Tư dùng tiếp.
Ở đây có thể setup xong rồi vào mùng 5 để họ dùng được không?
Bây giờ chị hỏi lại xem Ngân ở dưới kia hội trường nhà Hà Nội có còn nếu không lại kéo quân hội trường Hà Nội. Hà Nội thì chắc chắn là có lần rồi, có rồi, chị hỏi Ngân. Mệt thế.
We study?
Back's the problem.
A problem?
Yeah.
With the backs? Oh, too bad. We know that
Alo,
usually
Ngân à?
we have the same problem.
Alo, Ngân ơi.
Chị cái biện pháp là cho mình di chuyển xuống tầng mình được thôi. Sau vẫn nào ai cô.
Alo, Ngân à? Alo, alo, Ngân à? Chị bảo này, bây giờ mấy cái hội trường đấy, hội trường Hà Nội, mấy cái hội trường mà có dùng được bách
không phải link mà sẵn một máy ở dưới phương pháp.
Chị đang gọi Ngân à? Đây là đang gọi em.
À thế em gọi đi, hỏi xem. Còn cái hội trường nào không? Alo, Ngân à? Chị hỏi tí, mấy cái hội trường mà còn dùng được cái hệ thống trần đoán hình ảnh ở Hà Nội, Đà Nẵng với cả Tư Leo thì có mấy cái hội trường có hội trường nào mà đang chống tự nhiên được các bạn eco rồi
cái lồng các thứ dùng một bách máy móc ở trên này các học,
tức là còn hội trường nào rảnh không? Bây giờ tất cả
và cái máy ở giữa lên.
còn Hà Nội tất cả các hội vẫn như là tôi thì phải số tầng chỉ nhưng mà ngồi thì nó kiểu trực tiếp này là mới dễ hơn.
Còn nếu không
thế thì cái thà Hùng ngồi dưới chỗ Hùng có khi gần hệ thống điều khiển tốt hơn. Em xem như thế nào thì phù hợp hơn. Cái cô thì bình thường Hùng vẫn ngồi chỗ Hùng làm. Thế hay là ngồi tầng 8 nhà chị hay là chưa vào. Hình như được rồi đấy này.
Không, cái chỗ này nó chỉ là cái chỗ màn hình đăng nhập.
Thế thì để đành phải nhờ Hùng là Hùng chọn địa điểm ngồi đấy. Xong nữa thì Hùng xem. Thế Hùng xuống tầng 8 ngồi vậy hay là
thường xuống xem gọi hay phụ từ 8 lên
thì có anh Hạnh ở đây rồi thì Cường xuống ngồi với Hùng đi. Danh sách bệnh nhân thì cô gửi cho Hùng thì biết các bạn số rồi.
Thì em sẽ bây giờ đưa cả đoàn xuống xong rồi của chúng ngồi cho mất thời gian.
Thế cho Hùng nhé. Thì cảm ơn nhé.
Em đi xuống chỉ độ này xem bạn Hạnh thế nào.
Thế cho mày xong rồi mình lên đây cho nó.
Bây giờ xong được trước.
Ok.
You have a fax problem?
Then pathology imaging.
Imaging.
Then you go to
down. Down. You will be able to do it
connect,
and connect. Okay, good.
Thôi anh lên đây ngồi đi, bắt đầu đi.
Thì cứ là còn được xe từ lên.
Đã chơi kiểu online được vừa.
Có chờ anh ấy
Vừa trực tiếp vừa bạn gián tiếp.
Chị muốn xem là từ trực tiếp thì lại
thì đúng rồi, nhưng mà bây giờ chả có cách nào thì phải nghĩ giải pháp thế nào nó tối ưu hơn. Không ngờ là ở dưới kia tầng 3 thì lại chỉ có được dội đến 3 giờ thôi. Đến 3 giờ thì đến sau 3 giờ thì đuổi mình đâu. Nên là mình chịu.
Cái phần này cái trình bày trước thì đến chẩn đoán nhảy thì tính sau. Đúng không? Bắt đầu này. Đúng không?
Bật loa chưa?
Tôi à?
Bật đang bật đi. Từ nãy vừa nghe chuyện mình nói.
Vâng.
Chết mất. Now we can start. Excuse me, Dr. Michelle.
Yes.
Yeah, we can start.
Oh, yes.
Yeah.
Yes. I'm happy.
Yeah.
Happy to start.
Now, I'm very sorry, everybody, to delay start the afternoon section. This afternoon, we have 5 cases to discuss with France expert.
Recording in progress.
4 cases is a neuroblastoma and 1 case is a Hodgkin lymphoma. And now it starts the first case with neuroblastoma. I would like to invite Dr. Tram in the oncologist center to present this case.
Yes.
Thank you.
Hello everyone, I'm Tram and I will present a case about spinal canal invasive neuroblastoma. This is a boy 4 years old. He came to our hospital on July of 2024 when he was 33 months old. First clinical presentation was fever and abdominal pain. Clinical examination at that time, he was alert, clear breath sound bilaterally, no rails, regularly heart rhythm, palpable pulse, blood pressure normal. He has soft and distended abdomen, no palpable mass, no paralysis, no sphincter disturbance, pulse skill, and mucous membranes. The findings at that time, CBC was generally normal. AFP was normal, LDH was normal. We have some HVA and VMA was generally normal, and other biology test was normal too. We did perform bilateral VMA and it was normal too. On ultrasound and CT scan of abdomen, we find a right side retroperitoneal mass about 8 and 5 and 4 centimeter, moderately invading the spinal canal via the neuroforamina, forming an intraspinal component, nearly filling the sacral canal and expanding up to L4. It is measured about 5 and 3 and 1 centimeter. The chest DD was normal. Brain MRI at that time was normal. So we decided to perform a core needle biopsy of the retroperitoneal mass, and the histopathology of the mass show ganglion neuroblastoma intermix. So after TBM, he had a surgery on July of 2024. During the operation, we find a firm multi-lobulated tumor located anterior to the sacrum, poorly mobile, firmly adherent to the spine and extending into the neuroforamina. The mass was in close contact with multiple major abdominal vessels. Maximum resection of the extracanal portion of the tumor was resect and leaving a thin residual layer over the anterior surface of the spine, and the components within the spinal was can't resect. The pathology of the tumor after surgery was shown nodular ganglion neuroblastoma, differentiating subtype, and fish form MICAN application was negative. Assessment after surgery, the clinical findings, the patient has right lower limb paralysis without sphincter distinct dysfunction. Muscle strength of the right legs gradually improved with physiotherapy. And on ultrasound of abdomen, we find a hypoecho mass located in the intervertebral space of the sacrococcygeal region, about 2 centimeters. MRI of the bones and MRI of the bones was normal, and MRI of the spinal cord, we find a residual retroperitoneal tumor about 5 and about 30 and 12 millimeter extending into the spinal canal and forming interspinal mass. The patient was diagnosed with nodular ganglion neuroblastoma, differentiating subtype mechanism amplified, and we start treatment according to life protocol group 7. After 2 courses of VP carbo, the child was able to walk with my weakness of right legs. The muscle strength is 4, and the left leg was normal. In MRI, we also see the intraspinal component with no change inside compared with previous imaging. Chest CD was normal. After TBM results, we decided to intraspinal tumor resection. And the patient was performed intraspinal tumor resection on November of 2024. But the surgeon just resect near total tumor, and most of the tumor can't resect. The pathology of the component in intraspinal was show ganglion neuroblastoma in the mix. So we decided to continue treatment chemotherapy with 2 courses of VP carbo. And after two courses, the patient was complete total 4 courses of VP carbo and stop chemotherapy now and follow up 1 month until now, 1 year until now. For summarize, this is a 4-year-old boy present with abdominal pain and fever, no paralysis, and no sphincter disturbance at the time of admission. On a CT scan, we find a retroperitoneal tumor extending into spinal canal. Core biopsy show ganglion neuroblastoma mixed type. The first surgery, we maximal resection of the prevertebral mass, but the patient has residual in intervertebral, foraminal, and spinal canal. The pathology of the mass show ganglion neuroblastoma nodular, differentiating subtype mechanism amplified. So we decided to treat the patient with according to life protocol group 7. After re-evaluation, we decided to perform second surgery to try to resect the intraspinal lesion, but we can't resect this tumor. Now the patient complete additional 2 circles of VP couple and of therapy under regular follow-up and no signs of progression. So our question is, the first one is, after 2 courses of VP couple, the intraspinal mass show almost no change inside, and the patient did not develop worsening motor weakness. So was the surgical resection appropriate at that time? And the second question is, currently the child was still had residual intraspinal. Clinically, the right leg remains weak. Should surgery resection of the remain intraspinal lesson be reconsidered? Thank you.
Thank you, Dr. Tram. And this is an interesting case because we cannot control this situation because we like to take the comment and advice from the curing.
Can we have a look at the MRI, at
Yes.
diagnosis, and after surgery of the intra-abdominal, intrapelvic region? I think it's very important to look at the MRI because I think that you were right in a sense all along. All along you were right, but I think it's important to look back at how the tumor was and how it was after the first resection, and I like to know if really nothing more developed in terms of deficit. Was the surgery of the intraspinal components leading to more deficit or not? This is the only question I think which remains, because for such a situation, the very important thing is to avoid to harm the patient, because we know that in this situation, most of the cases in this situation of neuroblastoma or ganglion neuroblastoma have a good prognosis. Most of them, except in very rare cases where we have metastasis. But in this case, we knew from the beginning that it was not the biggest problem. The biggest problem was not the metastasis because it was intermixed. And then after the first surgery, it was a ganglion neuroblastoma differentiating.
Yes.
So with nodular type of differentiating. So we knew from the very beginning and after the surgery, the first surgery, that it was something which was not very aggressive in terms of pathology. So we would like to look at. I like to look at the first, which was in yes, here. We see the big one.
Yeah, this is MRI at the diagnosis in July last year.
Yeah.
So you can see there was a mass in the retroperitoneum in the pelvic region and anterior to the sacrooccipital bone, and the mass spread into the intervertebral column to the sacral spinal.
Can you show us the intraspinal component on a coronal view or on a sagittal view so that we see the upper part of the intraspinal? Okay, it's very high. It's in L4, yes. Okay. We scan in the over the vertebrae. Okay. Oh. What's going on?
It's spread from L4 to...
Sorry, we cannot see anymore. Oh yes, we can see. Okay. So can we look now at the MRI after the first surgery?
After first
surgery was in July, at the end of July, so it's probably in August. In August last year.
Có tháng 10.
Tháng 8 năm 2024 em ạ.
Yes.
Oh, in October, that's okay. If it's in October, it's okay also.
We don't have a sagittal view.
Okay.
It's axial and crown.
Yes.
It's a tumor in the.
Yes, in the spine. Okay. And can we look at it after surgery, after the spinal component surgery, which was in November? So after November, so December or January?
In January.
Yes, good. At the end of it.
You are in the final.
Il en reste.
Đây là tháng 1 chứ này. Tháng 1 là sao hai cái kết thúc hay là không, tháng 1 bên này là theo dõi rồi ạ, kết thúc từ kết thúc là tháng 10 thôi.
So can you describe what you see? Because I have the impression that there is something left.
Chụp cái phim này xong rồi.
There the spinal canal from.
Đây là sau hai đây không, còn cái phim của Thời.
From S5 to S3 and a part in the intervertebral.
Okay. Yes. Okay. So you still have a component in the sacral area, but the component in the lumbar area was taken. But you still have a component in the sacral area. Yes. Okay. And what about now? Now is most recent, must be something like we are in October, so maybe during the summer.
Okay.
Or in October, yes, you have it. Okay.
Maybe the same.
Yes, same. Yes. Yes, it's stable. And okay, so do you confirm this is stable between January and October?
It is January and it is in October.
Okay. And what do you think? What is your opinion about your? You see the same size or? It's not larger. It's not longer.
It is longer slightly.
Yes, but yeah, it's difficult. It's not a 25% increase. Maybe it's a slight increase, but it's not a huge increase. My understanding of this case is that it's a mature tumor, and this mature tumor does not respond to chemotherapy, whatever. So even if you use CADO, you will have toxicity, and you probably will not have more results. And now the question is, can we go with this without touching? This is your question. And I think the very important thing to tell is that probably if the surgeon was not touching the lower part of the tumor, it's because if you touch this part of the tumor, you will increase the sequelae with like the sphincterial sequelae, and this patient may have no function of the bladder nor of the anus. So I think that it's urgent not to do anything but physiotherapy, trying to help the patient with the re-education with physiotherapy, and maybe probably the foot of this child is not getting high. So probably you need to help with something under the foot, like a piece of plastic, which is helping the foot to be not too much like this, to become too equine. So I think that as long as this patient has no sphincterial effect of the tumor, it is important not to touch the tumor, because on some occasion I've seen cases where we were pushing the surgeon to take out this tumor in this area, and it was making a lot of problems after surgery. So I think it's wise to do what you have done, which was to make a partial resection of the intraspinal, confirm this is not an aggressive tumor. What you did, you had a ganglio neuroblastoma intermixed on that issue, and it was was okay. And I think that now you have to make just a follow-up and physiotherapy, because it's very important for this child that this child maybe this child is having difficulty to run, probably. Does he have a falling? Is he stepping or not?
He can run, but slower than his friends.
Okay.
Okay.
But no sphincterial abnormality.
No, he can run without the help of others.
Okay.
Yes.
Okay. So good.
Yeah.
So I think you did a good job. Definitely. Now, the only thing that can be discussed, but I think it's not the matter today, is that maybe in such situation we could avoid completely chemotherapy, but we don't know. We don't know, and we are not willing to harm the patient. So at least the chemotherapy which was given is not too aggressive, so it was not making big toxicity. And so 4 courses of BP carbo usually doesn't make any problem with the hearing, no hearing loss, and no renal toxicity. So you can follow this patient now.
Yes. Okay. I understand.
So how often are you going to do the MRI? What do you think?
3 months.
Now we follow up
every 3 months.
Every 3 months.
Because if it's stable, if it's continuing to be stable, you may have longer duration between 2 MRI. But now I think 3 months is fine. Okay.
Yeah. Thank you. Còn tóm lại là kết luận của cái ca này thì bác ấy nói là mình như thế là làm cũng ổn rồi, và cái tiên lượng của bệnh nhân thì không có quá nặng, và bây giờ thì sẽ dừng điều trị ở đây và không can thiệp gì thêm ngoài cái việc là tập phục hồi chức năng cho bệnh nhân. Và cái việc phục hồi chức năng thì cũng rất là quan trọng với cái đứa trẻ này, và mình sẽ theo dõi bệnh nhân và follow up mỗi 3 tháng một lần bằng cái cộng hưởng từ cho bệnh nhân, cộng từ cuộc sống cho bệnh nhân ạ. Không biết các đầu cầu các bạn có hỏi gì nữa không ạ? Ai có câu hỏi thì chúng ta giơ tay nhé. Nếu mà không có thì chúng tôi sẽ xin chuyển sang ca thứ 2 ạ. Mời bác sĩ Đỗ Phương ạ. We would like to invite Dr. Phương to present at the case.
Body. Okay. Hello everyone. Today I want to present a case about a patient with diagnosis neuroblastoma, and this patient is a girl. Date of birth is 3rd September 2022, and as diagnosis is less than 12 months, and clinical presentation in May 2023 is abdomen detention with medical history is normal. And when admission, she has respiratory failure and abdomen distension with no hypertension, and LGS is positive. And we do some investigation as elevate LDS and SVA and VMA in urine, and CT scan abdomen have a mass in the retroperitoneum. IDRF is positive, and continue with the mass in the posterior mediastinum. IDRF is positive, and no invasion of the spinal cord. We also performed the MRI brain and spinal, and we found some lesion in the bilateral wing of sphenoid bone, and spinal MRI is normal, and bone marrow is normal. And biopsy, the corneal biopsy is tumor in the retroperitoneum, and pathology is polydifferentiated neuroblastoma and mechanoamphiphile. And we run the CGS, and the ratio is SCA with 11 Q lot and 17 Q gain. And we also run the ALK is negative. This is the ratio of CGS. And we diagnosed this patient with polydifferentiated neuroblastoma, IDRF is positive, LTS, stage M, metastasis to sphenoid bone, less than 12 months, we can not apply, and SCI is positive, and we tested this patient like roof 10. This is the regimen of roof 10. And we diagnosis is May 2023, and we start the treatment with 2 VP couple, and after 2 VP couple we the and the tumor size is not changed very much, but the metastasis at sphenoid bone is PR. And we agree that we give this patient with Brustan and 2 more VP couple. And after 4 VP couple, we the adjustment, and we see the tumor is not change, not significant change, and we treat more 2 cardo. After 4 VP carbo and 2 cardo, with brain MRI, we see the no metastasis to sphenoid bone anymore. But just we see we think we cannot resect the tumor, and we are concerned as the first TBM at this time, and agree that we tested with IT, and if no response, radiotherapy. And to November 2024, we after 12 IT and radiotherapy, we end of treatment and follow up. At June 2025, and we think this patient has progressive disease because the size of tumor elevates, and we think is change in size about 40% in volume, and we concern us the third TPM, and we agree that we will chemotherapy with topotecan and anglosan, and hydrochemotherapy in response. And after 3 more topotecan and anglosan, and we found the tumor still cannot be resect, and no metastasis to brain, to bone and bone marrow. And we test more 1 topotecan and anglosan, and we do the second time biopsy. And we perform the second time biopsy at October 2025, and pathology is major ganglion tissue. And we have some summary about this patient. Occurred 8 months old as diagnosis, and as present now 3 years. And diagnosis polydifferentiated neuroblastoma, RDRF positive, stage M, less than 12 months, non-amplified, SCA positive, LTS, and ALK negative. And we total treatment with 4 VP couple, 2 CADO, 12 IT radiotherapy, and 4 topotecan anglosan. At present, tumor no significant change, no metastasis to brain, bone marrow, and bone. And pathology with the second biopsy in major ganglion tissue. And we have some question: should we stop treatment now and follow up? And maybe we think, should we do the second biopsy earlier in June 2025, and and should we do perform the second biopsy with all okay within the progressive disease? Thank you.
Can we have a look at the MRI or CT scan in November 24, local disease in November 24, and then in June, because I remember well that when we look at the MRI in June together, I was not sure that there was a progression, but when we looked, it was obvious that there was something going on locally. And this is a midline tumor, so it's very difficult to perform surgery in such a midline tumor. What is on the left? We see it's November. Okay.
Yes, in November 2024.
Yeah.
It is the tumor in posterior mediastinum and the retroperitoneum. Please. The tumor indicates the aorta, celiac mark, and mesenteric artery. In case the bilateral renal artery, and there was some nodule. Just a lymph node here.
And what about in June 25?
Thầy chậm thì bảo là phần cao, thầy bảo là chậm thì bảo là hai phần độ cao, nhưng mà ai lại có thể viết đâu chạy cái mỗi lần chậm.
Stable in size.
You cannot link the two CT scans in order to make a comparison.
In the left is in June.
Yes, it's June, so it seems to be larger, or maybe I am mistaken. I don't know. I have really the impression it's larger. So it's 52 in June, and on the right, it's 44, 43.
It's increased.
Yeah, it's not exactly the same place. Yes, okay. So, but I remember now, I remember well that we saw in June something which was larger in terms of soft tissue on the left side. And what is the status now? The status after the 3 or 4 courses of topocyclo, so which is recently, before the biopsy. There was a biopsy done recently, but in October. So if you have the CT scan in October, sorry. October this year.
MRI in the October.
October, if it's MRI, it's not exactly the same thing, but October, April, June 25. What is the most recent evaluation you have? On the right, I see October 25. On the right. On the, yes. It's an MRI.
Kỳ này tháng 9 có chụp CT mà.
Scan in September.
If you had the scan in September, it would be more accurate to make the comparison CT scan to CT scan.
Yes.
Thank you. C'est 25 ou c'est 24? Septembre 25, okay. Okay. Just so June on the left and September on the right.
It's on the right September and the left is in June.
June, and it's stable, or maybe 2 millimeters less. Okay, it's stable, and it's ganglioneuroma. It is, at least the specimen taken was showing ganglioneuroma. So, and on the, yes, the depth, okay, at least it's not growing. I think, thank you very much for showing us this. I think that in this situation, if I may, that this is, at the beginning, it's a stage M disease, so it's with metastases. And you gave to this patient a lot of chemotherapy, as expected, but after a while, the the primary was not shrinking, even with 12 courses of in danger of coming back in distant, like metastatic. And since it's at least stable with topocyclo, should we give high dose or something like that, even with ganglionic cells there in the primary? Or should we discuss now radiotherapy? And I think it's really a question because this disease seems to be somewhat resistant to chemotherapy, even if there is maturation. There is maturation after a while, because we see that, yet I understand, you asked me, should we have taken the biopsy at the time of progression in June? So we don't know, because we were not here to do it, and even since we did not know, we don't know if we would have seen less differentiating cells than now. At least now we know that there are mature ganglioneuroma here in the specimen which was taken. There is one thing which we don't want to do is surgery, because you have seen our colleague Ung from radiology showed us how this tumor is. This tumor is surrounding the aorta. It's taking the two renal arteries, the celiac axis, the superior mesenteric artery. So we don't want to make surgery to this place. The real question is, should we discuss for this case to have radiotherapy despite the fact that it is ganglionic cells which are seen on the microscopy, on the specimen? So I think this is really a question.
Tức là cái ca này là bây giờ cũng rất là khó, bởi vì mổ thì không mổ được, nó cũng không thể nào nói được là bây giờ nó đang bên thành thì nó bị xạ trị, nó chẳng có nghĩa gì, hóa chất test không biết
I think we can look at this case with Pascal later, but I doubt that she will be happy to propose a surgery at this level, because a surgery at this level is very dangerous. So I think there are two. Pascal, Sylvie told me maybe we can wait and see if by regrowing we decide to make radiotherapy. It would probably avoid to do radiotherapy in a child with now. She was born in September 22, so she's now 3 years old. She's 3 years old, and 3 years old, if she has radiotherapy, she will have a radiotherapy in this area.
Did she already receive radiotherapy?
When? No. Oh.
The patient receive radiotherapy.
Oh, she received radiotherapy. Oh.
Yep.
I was skipping that. I'm sorry.
After we discussed with
yes, after the second TDM. Yes, okay. I understand. I understand. I'm sorry.
The patient has a pulse.
Yes, so she had radiotherapy already. So I think that what we can do is to follow now and to see, wait and see. But I am always concerned in a patient like this who has a tumor with segmental abnormalities with 11q, because we know that people will have patients who have 11q loss and 17q gain, sometimes relapse very, very late. And they finally, at the end, eventually they die of disease. So I think that this is the reason we were asking to do all what we have done. Maybe I'm not confident in not doing anything. I'm not happy. but maybe we have no choice, because since we cannot do, again, radiotherapy, we have probably to wait and see. Because taking into account the fact that we see now ganglioneuroma, but it is a part of the tumor. So, and to the last question, since I come back, I go back and forth. I'm sorry, but the question maybe that you would have in mind is that if this patient relapse later on, maybe you will tell we should have done high dose therapy. If she relapses later, you may ask yourself, maybe we should have done high dose therapy at one moment. And since, remember, during the third TBM, we said if we see some response to topocyclo, we can propose high dose therapy.
Yeah.
This is maybe the last option that we, before stopping completely any treatment, is to give high dose. What do you think yourself? And you, Dr. Nguyen, what do you think? You are in charge of this patient, are you?
Yeah. I think we have only one child with this patient is and follow up, and if progression, maybe chemotherapy is the last choice we have.
Yes, but if you won't like to give high dose therapy without showing that there is some response. So if you wait and see progression, then you will have to change to something else, like some other type of chemotherapy. And I see the only chemotherapy I can see here, because this patient received everything except cisplatinum. So you could try, in case you follow up and you see progression. So you have the choice of doing two things. One thing is to give high dose therapy now. The other option is to follow up, and in case of progression, you give cisplatinum and VP16 high dose cisplatinum, because she was receiving only VP carbo so far, and it was a while ago. It was in May 2023. We are now in October 2025, and then you can probably reuse VP16 and cisplatinum. And then, if there is a response, to give only then high dose. So you can do high dose now or high dose later, in case there is progression. What would you prefer? And you, Dr.
I think we start with the family.
Yes, obviously. To talk with the family and say, we have the choice between two things. One, to put on the table high dose now, and one to put on the table high dose later in case of progression, but after checking that VP cisplatinum is functioning. And maybe by that time we will have the antibody available.
Maybe keep the patient survive until we have active
antibody. Okay. Okay, so you will talk with the family between the two things. Okay.
Okay.
I think it's nice. And maybe before the end of this week, we have to show to Dr. Pascal Philippe Chaumet what she thinks about the surgery, because I am not a surgeon.
Yes.
And or you are not a surgeon, I guess. So we have to ask the surgeon. Okay. Okay.
Yeah.
Do we do that way?
Yeah. But I have a question. If we do hydrochemotherapy in this patient, this will be no great radiotherapy after.
Yes.
And still treatment maintenance.
If you have regrowing, we have to look back at what Dr. Zui was giving as a dose. Was he giving a conventional dose? probably. And if he was giving a conventional dose and no extra dose because the disease was still present, maybe we can give radiotherapy after high dose. But if he was already getting 45 or something like that at the age of 3 years, no, I don't think so. Okay, so probably in case she has progression, the tumor is progressing, then you can give VP cisplatinum twice. If you see a response, you give Bumel, and then you can have 2 months later radiotherapy. Radiotherapy. Sure.
Now the patient has no metastasis, no metastasis, and only we have the tumor that's in no response to the chemotherapy, and we cannot remove the tumor.
Yeah.
So when do you think that she deserves chemotherapy, in knowing that when we give the high dose, we cannot remove the tumor?
Yeah. Yes, this is something we have done on several occasions. I remember even cases with weekend amplification with good response in distance, but the primary was on the midline, could not be resected, and we gave high dose, then radiotherapy. And the patient, at least I remember one who is surviving for a long time and is probably cured. So we can have the local treatment, the best local treatment is surgery plus radiotherapy. But in case we cannot do surgery, the local treatment is radiotherapy.
Chúng ta vừa mới kết thúc cái ca thứ 2 thì cái ca này thì là ca mà khối u nó cũng đáp ứng với cả điều trị hóa chất mà chúng ta đã dùng khá là nhiều rồi, có cả xạ trị rồi nhưng không thể phẫu thuật được vì là khối u bao rất là nhiều mạch máu. Thế thì tôi đã hội trần đến ca này đến lần thứ 4 với các bác chuyên gia rồi, và cái điều trị của bệnh nhân bây giờ thì có 2 sự lựa chọn. Một là chúng ta sẽ điều trị hóa trị liệu liều cao ngay lập tức. 2 là chúng ta chờ đợi theo dõi bệnh nhân cho đến khi mà u tiến triển trở lại thì chúng ta sẽ hóa trị liệu liều cao và ghép tế bào gốc. Thì với hóa trị liệu liều cao thì các bác cứ khuyên là dùng cisplatin và etoposide liều cao, sau đó thì sẽ dùng busulfan mefalan và ghép tế bào gốc. Thì cái này chúng ta và sau đấy thì có thể là bàn bạc với cả chuyên gia xạ trị để xạ trị tiếp. Thì trường hợp này thì chúng ta sẽ thảo luận với gia đình để xem chúng ta sẽ chờ đợi và theo dõi bệnh nhân đến u tiến triển hay là chúng ta sẽ hóa trị liệu liều cao luôn. Thì cái này sẽ trao đổi lại với cả gia đình bệnh nhân để chúng ta có một quyết định tiếp. Và cái trường hợp này thì cũng không thể biết được là chúng ta làm cái gì có thể tốt hơn cho bệnh nhân, bởi vì là chúng ta bệnh nhân thì có cái về mặt di truyền tế bào u thì nó có một cái biến đổi về mặt cấu trúc của nhiễm sắc thể, là cái mất đoạn đó thì nó rất hay là tái phát, nhưng mà tái phát muộn, nên là chính vì vậy chúng ta cũng sẽ phải theo dõi rất là chặt cái ca này, vì là cái khi mà bệnh nhân tái phát lại thì chúng ta sẽ phải điều trị rất là sớm bệnh nhân ạ. Thế thì có 2 cái lựa chọn như vậy thì chúng ta sẽ không biết là cái nào tốt hơn, và với cái trường hợp này thì cũng số ca nó không nhiều và các bác cũng chỉ thấy có một số cái ca nó có đáp ứng với cái việc mà các bác cái khuyên như vậy, thì chúng ta vẫn gọi là theo kinh nghiệm chúng ta làm về điều trị nó gọi là cây bay cây ạ. Có lẽ là chúng ta hết 2 ca, bây giờ chúng ta nghỉ giải lao độ 5-10 phút, sau đấy chúng ta còn 3 ca tiếp tục. Can we have a stop a little 10 minutes tea break and then come back?
Tea break or coffee break?
Yeah.
Oh, good.
Outside. Relax a little bit. 2 case difficult case.
Yes, about time.
Chúng ta nghỉ một chút rồi sau 10 phút chúng ta quay lại. 10 minutes.
10 minutes.
Yes.
Sufficient.
Cool.
Đó.
other neuroblastoma.
Good afternoon. My name is Thủy. Today I'm presenting third case of neuroblastoma. The patient is girl. She was 6 years old at diagnosis. She accidentally discovered adrenal tumor through abdominal ultrasound. Her medical history is normal. On clinical examination at the diagnosis, she was alert, no shortness of breath, no life-threatening symptoms. Her blood pressure was higher more than normal, about 130 and 19 millimeter of mercury. A diagnosis, the abdominal CT on June 2025, the right adrenal fossa has a mass mirroring 26 and 27 millimeter. No IDRF. The left adrenal fossa has a mass mirroring 24 and 20 millimeter. Has IDRS because the tumor in contact with the left renal vascular bundle. The right liver has a suspected secondary lesion, not measuring 7 millimeter. Chest CT and MRI, IMI are normal. HPA and BMA are normal. See a biopsy of her right adrenal mass, and the pathology is ganglioneuroma. She did surgery resection tumor on August 2025, and the pathology of right adrenal tumor is major ganglioneuroma. Tumor remains on cervical surface. The pathology of left adrenal tumor is ganglioneuroblastoma nodular, and the nodular history is histology is polydifferentiated neuroblastoma, unfavorable histology. Tumor remain on cervical surface. Neuroblastoma cell. Emic is non-amplified. Bone marrow aspiration bilateral are normal. The abdominal CT after surgery 1 month, image show country enhanced tissue in the left adrenal position, size 27 and 10 millimeter, not yet distinguishing residual tissue, tumor tissue, or post-operative hematoma. And summarize, the 6 years old girl, she accidental discover the bilateral adrenal tumor through abdominal ultrasound. She did the surgery resection tumor on August 2025. The pathology of left adrenal tumor is ganglioneuroblastoma nodular, and the tumor remain on cervical surface. Neuroblastoma cell. The diagnosis is ganglioneuroblastoma nodular, polydifferentiated neuroblastoma, state L2, and bigger non-amplified, and age more than 18 months old. And we had a question. This patient was diagnosis with ganglion neuroblastoma, fully differentiates. She looks thoroughly tumor resistant, but the tumor cell remain on the cervical margin. Should we continue to monitor or give chemotherapy for the patient? Thank you for attention.
Thank you. Before we look at the pre-op and post-op surgery, CT scan, I would like to know if what is the function of the suprarenal gland? Were 2 suprarenal glands resected at the same time, or is she not suprarenal insufficiency? Then she has suprarenal insufficiency. It's important to know when the surgery was done, was the suprarenal gland taken on both sides? Because, you know, this is an incident. We find a tumor in the suprarenal area on both sides. If we take out the 2 suprarenal glands, you may have troubles in the future if you do not give compensation. Do you know that or not?
We with resistant total tumor resistant part of right and left adrenal glands có một phần.
I think it's important to evaluate the cortisol in the morning. Do you have a good cortisol level in the morning, and do you have normal battery?
Nghĩa là họ cắt một phần cả một bên trái và bên phải của ấn tượng thận vẫn còn. Vâng.
So maybe we can come back to that after we see the CT scan, because if we see the CT scan and if we can see if there are residual suprarenal glands, that's okay. But it's nice also to know about the cortisol level in the morning and to see the sodium level also.
Stop saying.
Do you want to see the CT scan?
The CT scan at diagnosis and the CT scan after the second surgery.
Okay.
So you have only to look at the CT scan.
Yeah.
We cannot hear you. I see someone coming out of the shower. It happens sometimes. Yeah.
Il a entendu ce que tu as dit. Tout à l'heure, je demandais si je rêvais ou ce que
Oh, we don't hear well.
The bilateral adrenal fossa tumor is the right side.
Yes, not very large.
Yes. In the left side.
Okay. So in contact with the left renal artery. And can you show us the suprarenal gland on the left side? Is it distinct from the tumor? It was a good idea to look at the coronal view.
Khám nội tiết chưa? Không làm gì.
Moi, ça se pose page vers le terminal.
You can see a part of.
Yes, the posterior part. Yeah.
Yeah.
It's the posterior arm of the suprarenal gland. And here.
Con này mới một bên, con này cũ rồi, mới là con này.
Yes.
This is on right side.
Yeah.
Maybe this is on the left side.
Yeah. Okay.
And
yes. Can we look now at the post-op, at the post-surgical evaluation, which was most recent? It is October.
on the right side, the
Do you know why we don't hear him? We have a microphone problem. It's like it's.
Can you hear me?
Not well, not well. Now we.
Now it's better.
Bây giờ tốt rồi em ạ, nói lại đi.
On the right side, we can see, we still see the adrenal gland here.
Bravo. Good.
Maybe.
And on the left side.
It's still a part of the adrenal gland here, maybe.
Okay. Okay. Thank you. So can you were mentioning that there was some residual abnormality on the left area. Can you be more precise about the abnormality? Is it important? Is it very small?
Yes, on the left side, we can see there's that's here.
Yeah. Yeah, okay.
And
Okay. With contrast enhancement.
yes, it enhanced, so maybe it's the residual tumor or relapse tumor.
Yeah. Okay. Thank you. So you have basically, you were mentioning what, sorry, thank you very much for the images. You were mentioning L2 disease. So it's L2 disease, you say at the beginning, because you saw no radiological abnormalities on the right for the surgery, but you saw some image-defined risk factor on the left. But altogether, the surgery was done without pre-op chemotherapy. You didn't give any chemotherapy pre-operative. So, and I see that on the right side, this is a stage 1 tumor because it was completely resected. On the stage 2, we do not know. On the stage 2, we do not know if it's a stage 1 or stage 2 because we have no possibility to differentiate between the residual tumor or a scar which is enhanced by the contrast. So in any case, it's either a stage 1 or a stage 2 with unfavorable histology on the left side. So altogether, you have a case who has the worst prognosis is on the left side because it's a stage 2 with unfavorable histology. And we know from the experience of the American and PSYOP group that these patients who have stage 2 with unfavorable histology do not as good as patients with favorable histology. But it doesn't mean that we want to give them adjuvant chemotherapy. We have to be very careful about how to follow them. So the follow-up is going to be very important. So let's say in 2 months from now, you will have to see if the abnormality which was seen on this post-op scan did disappear or not. If it is a scar, it will disappear. If it's a disease, it may not disappear and not grow. If it's a disease, it may not disappear but grow. So in case it's growing, then you will have to discuss to treat this patient, to do again the summary of I don't see any disease outside, the bone marrow is normal and so on. So if I summarize the proposal for the follow-up is a close follow-up with CT scan in 2 months and then every 3 months. If you can see this abnormality on ultrasound, you could follow with ultrasound. If you see only with CT scan, you can only follow with CT scan in 2 months, then 3 months, and then 3 months till 1 year, okay? And then you can follow with only ultrasound. So I think this is very important to follow carefully this patient, because although the probability of relapse is higher in the group with unfavorable histology, is not that high. It's something like 30% probability of relapse. And since this patient was diagnosed with no symptoms, so it's also a strange story, because it's a patient with whom you describe something and you had no signs of disease prior to the discovery. So I think that this is what I would propose for the follow-up. But for the disease, I have something else to propose, because I think that it's not common at all to see a patient who is 7 years old, yes, 6 years old, I'm sorry, at diagnosis, and who has 2 suprarenal masses, 1 ganglioneuroma and 1 ganglioneuroblastoma with unfavorable features, with no predisposing things. So I think that there is one thing you can do, which is to try to document what is the CGH profile of the left gland, because you cannot do CGH profile on the right, because it's ganglioneuroma, you will have no CGH profile because it's full of stroma. So you can do a CGH profile on the left, and you can try to see if there is an ALK mutation on the somatic DNA of the tumor on the left side. In case you have ALK mutation, you have to look if this ALK mutation does exist at the constitutional level, because it means that this patient is harboring a risk of other neuroblastic tumor in the future, or to have children with risk of neuroblastoma tumor. So I think it's very important to discuss the case with the biologists who are in your institution, because Dr. and my know very well. My knows also very well, and they know very well how to do the CGH. They do the CGH. You showed us a very nice profile of CGH earlier today in the second case. So I think it's important to try to see with them if there is an abnormality in the CGH, and a mutation of ALK. Okay, that's it.
Yeah, okay. Tóm lại là ca này thì cũng rất là khó ạ. Một cái ca có vẻ là rất là hiếm là có hai cái u thượng thận. Một bên thì u hạch thần kinh trưởng thành, một bên thì u hạch thần kinh đang biệt hóa. Và với cái điều trị bây giờ thì và các bác cũng khuyên là chúng ta sẽ theo dõi, nhưng mà cái nguy cơ của bệnh nhân bị tái phát thì rất là cao, nên là chúng ta phải theo dõi rất là sát. Và chúng ta thời gian đầu thì chúng ta sẽ theo dõi 2 tháng một lần, sau đó thì 3 tháng một lần bằng chụp CT, và nếu ổn định thì chúng ta sẽ chỉ cần theo dõi bằng siêu âm thôi, không cần mà chụp CT nữa. Và nếu mà có thể được thì chúng ta sẽ làm phân tích cái CGS ở cái bên mà u hạch thần kinh đang trưởng thành để biết xem là bệnh nhân nó có bất thường về mặt di truyền của bệnh nhân, sinh học phân tử bệnh nhân không, và có thể có những quyết định tiếp theo. Và cả xét nghiệm ALK nữa, thì đấy là cái ca này thì chúng ta sẽ làm thêm những cái xét nghiệm để biết về đặc tính di truyền của u, và sẽ dừng lại ở đây và follow up bệnh nhân. Thank you for the first case. I would like to invite Dr. Linh from Oncology Center to present the first case. A lot of patients with neuroblastoma.
Yes, you have a lot of patients. It's like in Hue.
Yeah.
In Hue, they see also a lot of patients.
Yes.
With neuroblastoma.
Đã xe chưa?
Rồi.
Rồi, xe rồi. Em bị sâu to.
Hello everyone, my name is Kênh, and I would like to present as a case of neuroblastoma. Our patient is a girl, and she was 3 months old as diagnosis, and she was admitted in December 2024 with north abdominal ultrasound in a local hospital, identically detected an adrenal tumor. So he was transferred to National Children's Hospital, and her medical history is normal. And at Amazon, she was alert and she had short abdomen, no mass, and her blood pressure was normal. On the abdominal CT scan in April 2025, we found horseshoe kidney, and there was mass in the left adrenal fossa, measured about 5 centimeters. The mass puts the neighboring structure but does not invade, and contacting the left renal vascular bundle, EDRF were positive. So he was performed corneal biopsy, and the rest of pathology is polydifferentiated neuroblastoma, favorable history, and the bilateral bone marrow aspiration was normal. Brain MRI was normal. MECAN was not amplified, and the HVA and VMA level in urine elevated, and the CGS was NCA. So he was diagnosed with neuroblastoma L2, MECAN no amplification, age under 12 months, low LTS, and the CGS was NCA, and then he will follow up. This is abdominal CT scan at admission in December 2024, and in October 2025. Evaluation after 10 months of follow-up, we found that the tumor doesn't change so much inside. In December 2024, the size was 5 centimeters, and in October 2025, the size of tumor is still around 5 centimeters, but the HVA and VMA level in urine decreased significantly, and the clinical is still stable. To summarize, we had a girl 3 months old at diagnosis, and she was diagnosed with a polydifferentiated neuroblastoma in the left adrenal fossa L2 under 12 months. MECAN were not amplification, and CGS was NCA. and then he will follow up. And after 10 months of follow-up, we found that the size of tumor doesn't change so much. And so we would like to have one question. What should we do for the patient? Should we keep following up, or we should do a surgery for this patient? Thank you so much.
Thank you very much for asking the question. I think it's important to have a look at the first CT scan and the most recent CT scan. So if we can look at that with Dr. Hu. Dr. Hu. Can you show us the first CT and the most recent CT? I would like to ask you especially to show us the image-defined risk factors that were described during the presentation, please.
So it is CT scan at the diagnosis in December last year. So we can see the left adrenal fossa tumor. The tumor is in contact with the left adrenal vessels.
Yes, this is a horseshoe. Horseshoe kidney.
The tumor didn't invade the left kidney.
Yes.
Just right.
Okay, it's in contact with the left kidney, the left part of the kidney artery.
Yes.
Okay, and what is the situation now? Because I think it's important to see if it's different with the contact.
So on the left is CT scan most recently. The tumor is like
and can you go down on the recent scan? You see the contact with the artery? And on the coronal view, please. Don't you have the impression that there is more distance between the left renal artery and the tumor itself now? It was on the first CT scan, it was pushing the left renal artery, and on the present scan, we have the impression that the left renal artery is somewhat not as closed. Will you confirm or not? I am not a radiologist, sorry.
In the most recent, so tumor is a big and artery less than the previous.
Okay.
Yes, this just this part is in contact with tumor.
Yeah.
But it's not in contact.
Yes. Okay. But really, I have the impression that this tumor is smaller than it used to be. So it's a matter of discussion. Thank you very much for this presentation of the CT scan, Dr. Moon. My understanding is that this is an L2 tumor, but in a young child, in a young lady who was 3 months at diagnosis, and which tumor was at least not dramatically shrinking, but who had VMA and HVA going lower. And what we usually do in such a situation is to wait till the age of 1 year, which is the case because this patient was born in September, or till we have 1 year of follow-up, which is somewhat in December, because the diagnosis was made in December, and to make sure that we don't miss the shrinkage, the real shrinkage of the disease. You know, the German people who were the first people trying to observe the patient with in the neonatal period or under the age of 1 have shown that sometimes it takes 1 year to start to decrease. So the time for the decrease of the tumor can be long-lasting. So we try to recommend to start to postpone the timing of surgery till we give some chance to the patient to have his tumor shrinking by himself. Because the prognosis of this tumor is not bad in terms of biology, but if we have a trouble by surgery, it can be bad for the patient. So I think that if we can wait a little bit more, like 2-3 months, for example, do a new CT scan or only an ultrasound in 3 months, because to repeat the CT scan is a lot of things, it's a lot of irradiation. And I think if you can wait an additional 3 months and see if the decrease of the size is confirmed or is starting really, and then you can maybe continue to wait till it disappears by itself without action, or to make an easy surgery, because the idea is to have a surgery with the not very much problems with. So the size of the baby is larger, the tumor is getting outside of the area of danger for the left renal artery, and then it's easier to do for the surgeon. I regret that Pascal is not around to see this CT scan, but because I think she would say, for example, there is no risk or there is a risk to do surgery now. But I think that definitely, even if she says it's no risk to do surgery, I think we can still wait a little bit, like 3 months. And if you really need her, you can try to have her coming back for Christmas to do the surgery. Okay, so I would continue to follow up because you did a very good job to follow this patient. And you, what do you think?
Yeah. So you said that we should follow 1 year from the time of diagnosis.
It's what we did. We did that. We were sufficiently vague in terms of we made a study which was a study on neonatal masses, and the neonatal masses were followed with an idea that if this is neonatal, you will follow for 1 year, at least for 1 year. So it was neonatal masses. This one is a neonatal mass which was diagnosed at the age of 3 months. So if you can extend the surveillance to 1 year, you give more chance to the tumor to diminish by itself. So and the work which has been done on neonatal masses, I have somewhere, it was published by maybe by Papadakis, by Vassilios Papadakis as first author. It was published in the PBC. I can when I am back at the hotel, I can I can send you the documents, because it was a very good work which showed that we could avoid surgery in a lot of cases like this, as long as they had a tumor below 5 centimeters.
Yeah.
But this patient had the left adrenal mass of 5 centimeters largest diameter, but it showed already some sign of diminution, of shrinkage. So I think it's a good point to continue to follow this patient.
I have many patients. They were diagnosed when they are over 6 months. 6 months.
Yes.
So in the case of these patients, many patients have small tumor.
Yeah.
We cannot do biopsy. Need to biopsy.
Yes.
Only if we want to know what the pathology.
You have to take it out.
Yeah, but I choose to follow up. Yeah, I choose to wait.
Yeah.
Until the time of following up. How many times?
Yeah,
how long?
You never know, because you were not here before, and these tumors do something like this. They grow and then they diminish spontaneously. It's like the 4S's. It's like the MS case. And if you come at one moment, you don't know if you are before the higher part of the mountain, or if you are already on the other part, over the hill. So I think it's important to, as long as there are no life-threatening symptoms, as long as this is calm, you can follow up. I think it's much better. The thing that we could do in the future, but I think it's feasible, is to make a CGH profile on circulating DNA. Yeah. Because a large tumor of 5 centimeters, if you take the DNA which is circulating, you have cell-free DNA, and you can make the CGH on the cell-free DNA. So you extract the DNA from the blood, which is not in cells. And when you do you have very nice papers which have been written by Gudrun Schleiermacher from Curie, and who showed that you can have an information on the cell-free DNA, which is in the blood, in the serum, and you can compare the cell-free DNA to the DNA which were taken from the specimen of the primary tumor or from the metastases. So on a tumor like this, probably your patient who has something like 2 or 3 centimeters, you can try to see with mine if she can extract the cell-free DNA and make a CGH if you have sufficient amount of DNA. Okay.
Rồi ạ, chúng ta kết thúc ca thứ 4 ở đây. Với cái ca này thì bệnh nhân được chẩn đoán rất là bé, rất là nhỏ, và chúng tôi đã follow up bệnh nhân và muốn hỏi xem các thầy là có phẫu thuật ca này không. Thì với cái ca này thì cái khối u nó có thuyên giảm và cái việc mà follow up bệnh nhân thì nó rất là phù hợp, và các thầy cũng khuyên là chúng ta tiếp tục theo dõi bệnh nhân tiếp. Cái ca này ít nhất là 1 năm, ít nhất là 1 năm, và có thể là tức là follow up bao nhiêu lâu nữa thì cũng không ai trả lời được, nhưng mà ít nhất là 1 năm thì chúng ta follow up. Và bác sĩ Hoài Anh thì cũng có hỏi thêm về những cái ca mà khối u thì nhỏ dưới 5 cm và có thể là bệnh nhân 6 tháng tuổi thì chúng ta sẽ làm thế nào, thì các bác ấy chúng ta có nên phẫu thuật hay không, thì các bác ấy cũng nói rằng là chúng ta vẫn có thể theo dõi tiếp. Và chúng ta ở bên Pháp thì họ có làm một cái xét nghiệm DNA ở máu ngoại vi để xem là cái so sánh giữa cái biến đổi di truyền của tế bào ở khối u với cả cái DNA ở máu ngoại vi thì nó có cái sự khác biệt gì không, và có thể từ đó mà có thể có cái quyết định về tiên lượng của bệnh nhân và xử lý ạ. Thì bác cũng nói là nếu mà có bệnh nhân như vậy thì cũng liên hệ với bác để tách chiết DNA từ máu ngoại vi để xem là nó có biến đổi gì không. Dịch có gì thiếu không? Rồi, thank you for Dr. Linh, and we continue discuss concern is the fifth case. The fifth case is a Hodgkin lymphoma, but I think maybe with Dr. Naila, because we have some question for the image diagnosis, classification for staging, and then maybe
do you have
we move to the other rhabdomyosarcoma.
Oh,
it's okay.
Oh, you have another case.
Yes. We
have many cases.
Yes, maybe
other cases.
You decide, but I think it's if you say we need Naila, we can wait for Naila and do it in the week.
Yeah, maybe
it's up to you, but it's better to have the good people. But you have Dr. Hung. Dr. Hung.
Hung, yeah.
Yeah, he is around.
Yeah. He's around, but it's this Hodgkin's lymphoma. We the doctor from the military hospital.
From military hospital.
Want to ask a specialist.
Okay, good.
Maybe is
okay.
Maybe is have
we do it with Naila.
Staging problem,
Okay,
and then we would like in our hospital diagnosis the stage 4. But they think about the not stage 4, and then maybe have some question.
You have a TEP scan, FDG TEP scan or not?
No, PET scan in PET-CT in the before we make diagnosis by stage 4 bone metastasis by
bone metastasis.
Yeah, by MRI.
Oh yes.
Yeah, but
yes, it's a good way to do.
But the appeal is
we'll look at with
then maybe
with
Dr.
Naila.
Yeah.
Okay, good. So what do we do? Do we do something else? Hodgkin? No. It's Hodgkin, ça tient. Ok. Ils veulent pas du Naila. Moi, c'est impossible ce truc-là.
Je travaille, t'as 3 mètres de laisser.
Ouais. C'est dangereux.
Et
Một cái vậy à chị? Một cái rồi chị gửi.
Em đi mở cho chị cái. Chị đang loay hoay. Ông lúc nãy chưa nhìn thấy đồng chí. Vâng, đúng rồi đấy. Tại vì chưa nhìn thấy nên phải tự làm. Ơi chị đây. Lên trên tầng 14 sát hạch cái cung tầng 14.
Đúng rồi, xong rồi ví dụ như nó có thể nó lại cái chỗ nào đấy và nó lại trò gì đấy.
Xong cái này là
báo chí xong rồi mình lại đi mình dọn.
The surgeon will come.
Oh, the surgeon will come.
Dr. Pascal.
Dr. Pascal.
Pascal ini lalu datang.
Okay.
So we do the RMS and then we do our kit.
Now is the rhabdomyosarcoma first.
Rhabdomyosarcoma first. And after that we go to bed.
I would like to present a case of rhabdomyosarcoma, and our patient is male. He was 8 years old at diagnosis, and he was admitted in June 2025 with vomiting and headache. At admission, he was alert and he had sign of increase in intracranial pressure with vomiting and headache. He had right side hemiparesis, and he had normal heart rate and blood pressure. He had no abnormal lymph nodes and no fever. On the brain MRI in June 2025, we found a soft tissue mass in the right vertical palatine fossa measuring about 4 centimeters. It's suspected to originate from the medial pterygoid muscle and so strong hemorrhagic enhancement after contrast administration and sphenoid wing bone destruction. And then he will perform tumor resection at other hospital. And then he come back to National Children's Hospital in August 2025. And on the brain MRI after surgery, we found the mass still a mass increase inside, measuring about 6 centimeters with invasion of the cavernous sinus and associated sphenoid wing bone destruction. And spinal MRI was normal. The chest CT and abdominal CT was normal. Bone marrow aspiration was normal, and CSF fluid was normal. And the history after surgery was alveolar rhabdomyosarcoma, and the fossil 1 were negative. And then he was diagnosed with rhabdomyosarcoma group D, high risk. And then he was treated according to MIF 2005 protocol. Evaluation after 3 courses of EVR, we found that on the brain MRI, the mass decreased in size from 6 centimeters to just about 4 centimeters, but still invasion of the cavernous sinus and associated sphenoid wing bone destruction. And we discussed with the surgeon, and we found that surgery is very difficult and risk of skull bone injury. And we thinking about radiotherapy. And so we have summarized. We have a 8-year-old male patient. He was admitted with vomiting and headache. And on the brain MRI, there was a mass size about 6 centimeters and associated sphenoid wing bone destruction. And the history was alveolar rhabdomyosarcoma with fossil 1 were negative, and he was diagnosed with rhabdomyosarcoma group D. And after 3 courses of EVR, the tumor decreased in size from 6 centimeters to about 4 centimeters, but still invasion of the cavernous sinus, and surgery is very difficult. So our question is, because tumor has invaded in the skull base and surgery is very difficult, so we would like to ask about what is the next treatment, and we would like to ask about radiotherapy plan for this patient. Thank you so much.
Désespoir. I'm despair. This is despair for me, because we have been working with you for many years, but still you have the poor chance to have surgeons who wants to operate this patient first without discussion. I don't know where it was, but where it was somewhere else, obviously. But really, this is despair, because those patients have a dismal prognosis when you have an invasion of the cavernous sinus. cavernous sinus. It's more than the parameningeal. It's almost meningeal area. So I think it's really a poor prognosis. But definitely, even with poor prognosis, if you look back at the proposal for treatment of group D patients, you evaluate after 3 courses of the IVA, and you decide to do the local treatment.
And the local treatment is radiotherapy.
Exclusive radiotherapy, definitely. So I think it's nice to look at the CT scan now, but definitely it would have been radiotherapy first from the diagnosis, from the very date of the diagnosis. I hope you have the CT scan of the prior to surgery, or you don't have it. You have it prior to surgery. It was in June. Yes, but it's in August already. So you don't have it in June. Probably. I see something in June, yes. I see an MRI of June.
Yes.
Can we have a look?
MRI in June.
Prior to MRI.
Prior to surgery?
Surgery.
The MRI there was mass in the territorial phosphor on the right side here.
Is it really pre or post surgery? You know the date of surgery, Dr. Lin? Do you know the date of surgery of these patients? I have the impression it's not a tumor which was described by the primary MRI.
Nó mổ với tức mà. Thì không đi trong này không mổ với nào.
Thì đã cháu em nghĩ là nó mổ ở giữa.
Excuse me, he was performed surgery at another hospital, so we didn't know exactly the date of surgery. We just know that he was with the surgery in July 2020.
In June? Or in July? July. So if it's in July, this MRI is the pre-op. It's the pre-surgical MRI. No, this one is August. It's August. It's after report.
Nhưng mà nó chụp phim đầu tiên. Có chụp phim là ở viện Nhi trước khi mổ. Nó có một cái phim tháng 6. Chị em nói đi.
In June it's pre-op. It's pre-surgery.
Yes.
If the surgery was done in July, it's simple. Resection in July, because it was in an area where the surgeon was very happy to go.
I remember that the patient was concerned with the neurosurgeon in my hospital, and they could not biopsy, so they transfer the patient
to. It's too bad. Without discussing with you.
No.
Very, very. I think any patient who comes to this hospital, if there is a suspicion of tumor, should be discussed with your team anyway, in any circumstances, never with anybody else. If the patient is here in this hospital, the case has to be discussed without discussion with you guys and girls, because otherwise, you have the story that happened here, because you can show us that the tumor is not that large prior to surgery, but after surgery the tumor is larger.
Yes.
Okay. Now it's in August. In August, we see.
In August, the tumor is larger and destruction.
Yeah. Dr. Hu is going to tell us. Can you tell us how large it is from your point of view? Yeah. Yes, yes. So this is MRI. This is in August. Okay.
I know.
Okay. Four by four. Yes.
Flat.
Yeah. And the sinus, cavernous sinus. Yeah. It's invading.
It's the tumor invading.
We can't hear you. Oh, yeah. Yeah. Look at sagittal, it's too small. When you look at coronal, it's very large. Okay, yeah. Okay, so and what is the status now after 3 IVA? Can you show us what is the status now? Yeah. After 3 cycles.
It's a decrease in size. Now measure on Q2.
C'est où ce que tu peux voir?
Il était envahi par la tumeur alors qu'il n'était pas.
À gauche, là, il est. Ah, mais là, il est, ça, c'est avant.
C'est avant, c'est before and after.
Après, là, il est, tu vois, si tu suis la carotide, la masse qui est devant, là, entre la carotide, l'ethmoïde, là, ce qu'il prend, c'est la fin du sucre céramique, quand il revient, tu verras qu'il va faire.
C'est vieux, mais c'est quand même encore.
Okay.
Tumor decrease a lot.
Yeah.
Surtout il y a des ossos, ce qui est impressionnant. Là, sur celle-là, ça disait le tribus, ça va.
Yeah. Celle qui aussi France. Oh my God. So, what do you think for the timing of radiation now?
The irradiation, we do the irradiation after it at 12 weeks. So after 3 courses, just after 3 courses for the local treatment, so irradiation, exclusive irradiation, and with the maximal dose we can do there. In this protocol, it was 54 gray. In the new protocol, for RMS, you can do a dose higher until 59.4 gray. So
Is it randomized in the protocol?
In the new, yes, but he is not in the new protocol.
Yeah.
He is in the RMS 2005. That is included in the protocol or no? Is treated as
per protocol. The protocol
so
you are
you
using.
can do the dose as you want.
Yeah.
And I think you need, because it was the first surgery and the second one and very large and the partial response to chemotherapy. So you do the higher dose you can do. But who will irradiate this with the radiation oncology through therapy?
We intend to Dr. Di. Di ơi, có ý kiến Di ơi? Di ơi, ca này xạ được đến lúc này được xạ được chưa và liều xạ thế nào? Kế hoạch nào hả?
We can see that tomorrow at Hospital. Is in Hospital?
Yeah. Usually it's a difficult case. We just we refer patient to the Huế.
Yes, but this patient is 8 years old. He's 8 years old. Bah, pourquoi pas aller au... Ouais. So I think it's probably not necessary to refer to Huế. If he's 8 years old, he doesn't need general anesthesia. So probably it can be irradiated by Dr. Nung in K Hospital. It depends on you, but really we are in the same week, in the same team all together. And Sylvie proposed to see the case tomorrow with Dr. Nung or during the week, so that we can very rapidly proceed. Because 12 okay.
Chị ơi, mở được máy mic chưa em?
Okay, for this case.
Please here.
Hi.
How is the flood?
It's okay now. It's okay now, but we have a big time of flood.
Okay. What
for this case, the baby is 8 years old, so easy to do the radiotherapy. And the first choice for the case is the proton beam therapy, but we have no proton beam. For this case, you must do the VMAT technique. Maybe in National Oncology Hospital, K Hospital with Dr. Nguyen or with me. So prepare, please prepare on the imaging, DICOM, CT, MRI on the first time after operation and after chemotherapy 3 cycles. We make a plan very, very strictly. That's a case very high risk of local recurrence. And so for this case, we use the maximum dose for the tumor residual. And for this case, with me, I will give the tumor bed on the primary tumor. It means that the tumor progression after surgery with the dose at least 50.4 grade. And I will carefully boost to the residual tumor up to 55.9 grade. It's okay. Do you agree with me, Dr. Sylvia?
Okay. Yes. Okay. I agree. I agree with you. Perhaps we can do a dose until 59.4 grade. Okay.
59.4. Yeah, if 59.4, we can preserve the chiasma.
Yeah.
Okay. So we will discuss with family, with parents, that with the dose maximum 59.4 grade, we cannot preserve vision.
Yes, but we can try to do this dose 59.4 grade and to try to preserve the dose of 54 grade on the optic nerves and chiasm.
Yeah.
But with a VMAT technique, sure, arc therapy technique. But 54 grade, it's a good option.
Yeah,
Yes, I agree.
Yeah, And one more question about the cervical lymph node for this case. On MRI or CT scan, is there any lymph node on the right side? When the tumor progression, maybe the lymph node on the right side of the cervical. Please carefully.
Yeah. Okay. I didn't see any notes, but it's not very frequent. If not for this rhabdomyosarcoma in this localization.
Yes, and for this case, I thought in image in MRI and CT scan, the tumor is very large, many organs involvement, and also the inside the carotid, internal carotid invade. So the dose, maximum dose may be dangerous for the carotid, internal carotids, and also concerned about the dose. Yeah, and for this case with me, I will do the maximum dose is 54 gray for safety for the patient, and I concern very strictly increase the dose to up to 59.4, very dangerous. Yeah.
Okay. Yeah.
Thank you.
Thank you.
Thank you, Dr. Duy.
Yeah, thank you so much.
Sorry
Dr.
that you are.
Yeah, sorry.
Yeah.
Duy ơi, dịch ngắn gọn tóm tắt đi cho các mọi người cùng nghe với.
Vâng. Cái này thì một cái trường hợp một cái alveolar rhabdomyosarcoma của vùng nền sọ và nó xâm lấn đến cái xương bướm, xương bướm mặt cẳng trong, xâm lấn mặt cẳng trong, xâm lấn cái sông sàng, sông hàm và đến nền sọ vào trong cái màng não, mà nó rất gần với cái dây thần kinh thị và cái giáo thoát thị giác. Như vậy cái liều xạ nó rất là cao, bởi vì nó nguy cơ cao ở nhiều yếu tố. Cái thứ nhất là phẫu thuật đi trước, cái thứ hai là lan can, cái thứ ba nữa là nó liên quan tới rất là nhiều cái yếu tố nguy cơ cao, cho nên cái liều xạ ở đấy không phải dùng cái liều xạ tối đa có thể. Liều xạ tối đa có thể là đối với rhabdomyosarcoma là 59.4, nhưng mà trở với trường hợp này thì 59.4 là rất là nguy hiểm ở chỗ là bệnh nhân sẽ bị mù, nó sẽ bị hư cái giác thoát thị giác và hư dây thần thị. Cái thứ hai nữa là cái động mạch cảnh là cũng là một cái phần cơ quan nguy cấp, cho nên nếu mà dùng liều 59.4 nó có thể gây cái tổn thương về động mạch cảnh. Cho nên cái liều thống nhất với CNV sẽ dùng liều 50.4 đối với cái u ban đầu khi mà nó tiến triển sau mổ, và bút lên cho đến 54 giây đối với cái u tồn lưu. That's all.
Rồi, chị cảm ơn. Yeah, thank you.
Thank you.
Rồi ạ, bác sĩ Duy đã vừa mới dịch sơ bộ thì cái ca này chúng ta sẽ đến lúc này chúng ta sẽ xạ. Thì cái bệnh nhân này 8 tuổi, chúng ta có thể xạ không gây mê và có thể xạ nếu mà bệnh nhân không phải gây mê thì sẽ có thể xạ ở bệnh viện ca hoặc là ở các cơ sở mà không có gây mê. Nhưng mà theo bác sĩ Hoài Anh nói là bệnh nhân tuy rằng 8 tuổi nhưng mà rất là quấy và sẽ phải cần gây mê để xạ. Thế thì chị sẽ trao đổi gia đình để chúng ta có thể xạ ở nơi nào phù hợp, và cái liều xạ rất là cao.
Có một vấn đề nữa là có hóa trị trong xạ lưu ý ạ.
Có ạ, có. Vâng, cảm ơn anh Duy. Tiếp theo thì ca cuối cùng chúng tôi muốn hội chẩn một ca về u lympho Hodgkin ạ. Thì we would like to invite Dr. Phương present the case Hodgkin's disease. The case would like to make a diagnosis and state classified states and make plan of the radiotherapy. Mời các bạn đồng nghiệp ở bệnh viện 108 xạ, có ai vào chưa? Nếu mà các bạn đã vào dự rồi thì giơ tay để chúng tôi có thể mở mic, chúng ta có thể trao đổi với nhau ca này ạ.
Hello everyone. I want to present another case. This case of diagnosis Hodgkin lymphoma. Màn hình sao lại? This patient, a boy, have 11-year-old diagnosis and with clinical history with the fatigue, neuropathy, and weight loss 6 kilograms over 3 months, and accompanied by productive cost and progressively enlarging mass in the left cervical region, and no dyspnea or chest pain were reported. And a clinical examination at diagnosis, we have no sign of respiratory distress, and he has a superior venous canal syndrome, a firm non-mobile mass upper in the left supraclavicular region, decreased breath of the left lung, and normal ventilation on the right lung. Her sound were regular and clear, and normal and no hypertension. And we have a chest scan, a last mediastinal mass, and enlarged the mediastinal lymph node, compressing and narrowing the marrow blood vessel and the trachea, and bilateral floral effusion. And we has a cell block of floral wrist and no tumor cell, and bone marrow, 2 bone marrow aspiration, no tumor cell. And we biopsy, emergency biopsy this month, and we run the flow cytometry, and we think it's a T-cell lymphoma, lymphoplastic lymphoma. And at this time, we diagnosed this patient an anterior mediastinal T-cell lymphoplastic lymphoma, and we treatment this patient with ALL 1434 protocol with vincristine, donosubicin, methotrexate, intrathecal, and laspaza. And but after more than 2 weeks after treatment, pleural effusion saw was no improvement, and superior vena canal syndrome persisted. No reduction in the size of the supraclavicular lymph node, and we concern us TBM, and we decide to concern the pathology to with Kênh hospital, and the evaluation the primary tumor and other side. And his and pathology consultation is not malignant tumor of uncertain origin, and we have multi lymph nodes mass involving the pleural and upper left side pneumothorax, the left mediastinal mass, and thrombocyte of the internal jugular vein and subclavian vein extending to the superior venous canal. And we at MRI, we found the bone marrow lesion involving the vertebral body from the C2 to D2, with and brain MRI is normal, and we do an open biopsy, and the specimen was sent to the Kênh hospital for considering the pathology. And after that, we saw prominent fibrosis from brain that encased inflammatory cell arrest and lymphocytes within the stroma, creating a nodular sclerosis pattern. Numerous large polymorphic cells, including LNS cell and Ristenberg light cell, were observed. Immunohistochemistry chemistry revealed that the last cell was strongly positive for CD15, CD30, 30, and EMA, and ALK is negative. And we diagnosed this patient consistent with nodular nodular sclerosis, classical Hodgkin lymphoma, and SATIS4. And we have a PET scan after AALL1434, but before the treatment Hodgkin lymphoma. And we find a few bilateral level 2A cervical lymph nodes and increase the SUV. And mutive bilateral level 4 cervical lymph node, left level 5, and bilateral supraclavicular nodes. So no increase the FDA uptake. And anterior mediastinal soft tissue mass with the scasterized pulmonary nodule in the left lung demonstrates increased the FDA uptake. And hypermetabolic mediastinal lymphadenopathy along the right paratarsal, precarinal, subcarinal, para-aortic region, and bilateral hilar nodes with high SUV. And mutive bilateral axillary lymph node and a left interprostoral node with mildly FDA avage. And we diagnose this nodular sclerosis, classical Hodgkin lymphoma stage 4B. And because we think the bone lesion involving the vertebral body from C2 to D2 is the tumor involvement. And with treatment this patient with Hodgkin erroneous PSLC1 protocol with the 2 cycle of OEPA. And after 2 OEPA, chastity anterior mediastinal mass reduced to about 5 centimeters, and residual pulmonary nodule decrease inside, and but the right renal lesion untrained, and we cannot perform the PET at this time because at this time is not available. MRI is right humeral has lesion reduced inside compared to the to before, and we continue to treat this patient with 4 cycles of Kodak. And after 4 more cycles of Kodak, we re-evaluation and chastity at this time anterior mediastinal mass feels reduced to about 4 centimeters, no intravascular thrombosis, and still have some nodule in segment S1, S2, S3 of the left upper lobe, and largest mediastinal node about 12 millimeters. And we whole body MRI, we have no residual humeral lesion and persistent bone marrow involvement from C2 to D2. And the PET scan after 4 more cycle of Kodak, we have bilateral level 2A, level 4, level 5B, and bilateral supraclavicular lymph node has decreased in both size and number, with no increased FDA uptake and no residual FDG at 5 lymph node detected in the axillary region, left infrarespiratory area, or mediastinum. Under anterior mediastinal soft tissue mass with no FDA uptake, and skeletal nodule in the left upper lobe lacked 14 millimeters, so increase the FDA uptake with high SUV, and subcutaneous infiltration in the left chest wall with merely increase the FDA uptake, reduce inside and the metabolic activity compared to the December 2024. And we concern with Dr. Michelle by email, and we agree to continue treatment this patient with 2 more cycle of Copdac, and with adding brentuzumab. And now, after 2 cycle of Copdac with brentuzumab, PET scan increased soft tissue density lesion measuring about 3 centimeters in the right anterior mediastinum, with increased FDA uptake, SUV, high SUV enhancement in the left anterior mediastinum and left chest wall, with mildly increased FDA uptake, several bilateral cervical lymph node, root 2A less than 1 centimeter with increased FDA uptake, SUV max 4.4 and lightly inflammation, and several lymph node at the hepatic and hepatic hilum and the larynx about 1 centimeter increase the FDA uptake, and a nodule measuring in the measuring the 13 and 11 millimeter in the peripheral region of the left upper lung lobe with increased FDA uptake, and we decide to surgery the residual tumor resection about September 2025, and pathology is no viable tumor cell, both in the mediastinum and in the lung. Okay. And summary, we have a male 12-year-old with diagnosis with nodular steroids, classical Hodgkin lymphoma, stage 4B, and with treatment with Hodgkin Arones VSLC1 protocol TZ3, with 2 cycle of OAPA, 2 cycle of Copdac, and 2 more cycle of Copdac and brentuzumab. Now we think in the case response, patient was not in overall completion and have internal lesion in the lung and subcutaneous infiltration in the left chest were persistent positive in PET scan, and pathology after chemo is no viable tumor cell. And we have some questions. We grouped this patient as stage 4B because the bone lesion on MRI. Is that correct? And how can we confirm that? And should we do radiotherapy in this patient? And what's those? Thank you.
I can answer the first question because I don't care about the bone disease diagnosis. I do care about the large mediastinum story plus the pulmonary lesion that were described, at least in your presentation. You described pulmonary and nodules in the pleural area with pleural effusion. Even with negative pleural liquid, if you have pleural nodule in Hodgkin lymphoma, it means that there is pleural lesion at diagnosis. This is the first thing. So I think it's not a problem, because even if it was stage 3, the fact that you have a large mediastinum, as described, you will treat this patient like a stage 4. A stage 3B or a stage 4B are treated the same way, in a sense that you give to this patient the same OEPA at diagnosis, the two first OEPA. So I think it's not the big question. I have one question before we go to the rest. I'm interested to know how the diagnosis of lymphoblastic lymphoma was done. Was it on cell suspension, aspirates, or was it on histology? Because this patient was in a big distress, he had vena cava superior syndrome. You made probably not a big biopsy. You made a cytoaspirates of the primary of the lymph node disease, or did you do a histopathology?
This patient does the emergency core needle biopsy. The mass at the mediastinal, and because the ratio of flow symmetry, think about the T-cell lymphoma.
Sure. I'm not complaining. I'm not telling this is wrong. I'm just telling that if you rely on T-cell on cytometry, you may have a lot of infiltrating T-cells that tell you this is a T-cell lymphoma because you have a big mass and you have T-cell phenotype on the cytometry, but this is not the same thing as doing histochemistry, immunohistochemistry. When you do immunohistochemistry, you see that the cells which are positive for T-cell markers are infiltrating cells. You understand what I mean?
Yeah.
Because if you do the immunohistochemistry on the biopsy, you will definitely see that it's not a T-cell lymphoma, because you see that these are infiltrating cells which are T-cell positive, the T-cell markers. So I think it's just a problem of diagnosis, which is not your fault as pediatrician, but this is a problem that I have encountered in myself when we have people in the cytology department or immunohematology department which are not talking to people in histopathology department. Those people have to convene together to make the diagnosis not only on one side, but on both sides at the same time. So this is just an information for future cases where you need to have really people working more together between the pathology, cytopathology, immunophenotype, and immunohistochemistry. For the rest of the story, I think you made a great job, because this patient was unlucky to be diagnosed with T-cell lymphoma, but you were able to recapitulate with a Hodgkin disease treatment. The poor thing also was that he was unlucky enough to have no PET FDG available after 2 courses of OEPA. And then what you did was to be very efficient, giving the COPDAC and so on. What I don't understand is the story of the PET FDG, which is almost negative after 4 COPDAC, and which became positive after 2 COPDAC plus brentuximab. And since I have no experience of that, I think we should ask the person, Catherine Hermiston, who was proposing that, because I don't know what the brentuximab does in terms of attracting, infiltrating lymphocytes. Brentuximab is an antibody with some chemotherapy in it, added to it, so it can kill the cells and have lymphocyte coming. or macrophages, whatever, who are going to eat a lot of glucose and are going to be positive with PET scan. So I think we need to have I cannot, but I don't know if you can, but I cannot give any advice in a situation like this because I have no experience of PET scan after giving 2 contact together with rituximab. You understand the idea? But the last thing I want to tell, but it's my point of view, but I will listen to others, is that since you made the effort of trying to get cells, so to make a biopsy at the end of it, and you took probably a good piece of a good chunk of meat to make the diagnosis. If you don't find any cells, this patient received 2 + 6 plus rituximab. What can we do now? With no cells, what can we do? Do you want to irradiate? Do you think you should irradiate?
Huh?
No. No, I think it's my point of view. I'm not the chief of hospital.
We define the target for the irradiation in this patient. So there is no variable sex. I think the treatment was very large. And it's enough. We know no irradiation.
You know, many patients are cured with stage 4 disease, Hodgkin lymphoma, only with 2 OAPE plus 4 contact without irradiation.
Yes.
So many patients are cured with that because it's a very good approach. In case you have relapse later, you can use BCOP, you can use all kinds of things, and you can use other drugs and do the mini beam or the beam, whatever. But I think that this patient received a lot of chemotherapy, and I think it's looked enough.
Cái số 2 cô mình rất tốt. Sau 2
cái vấn đề là sao phải số cuốn này không chụp bé.
Không biết không bây giờ mà kể cả chụp thì kể cả tụt. Excuse me, Dr. Naila, maybe you look at the MRI to make the diagnosis, classify staging for the patient because we see the lesion in the bone. Then, Hồng ơi mở cái MRI của bệnh nhân này giúp luôn cho chị đã.
Cô stop xe cho em.
Chị có stop xe ạ? Stop xe.
Đây.
Cái gì chỗ nào stop xe à?
Chỗ này. Xe rồi chứ, stop rồi chứ. Chưa stop.
Không, phải Linh stop xe Linh. Chờ tí em ạ. Với cái ca này thì sau khi mà thảo luận thì các bác ấy nói rằng là cũng không cần phải xạ, bởi vì là mình sinh thiết cái tổn thương thì nó không có tế bào sống, nên là các tế bào nó chết hết rồi, nên là mình cũng không cần phải xạ nữa. Và mình cũng đang muốn hỏi thêm về cái phân giai đoạn của bệnh nhân, vì là trên phim cộng hưởng từ bệnh nhân thì nó có tổn thương, không biết là cái phân không hiểu nó ở đâu.
Hỏi khi nó ở đâu? À đây, stop xe. Sorry.
Nhiều cái đầu không xạ, bởi vì là nó tổn thương, nó bị dai dẳng nên mình nghĩ là phải xạ, nhưng mà bây giờ bán bảo không xạ. Khi bán bảo là patient tâm hỏi sợ là trong điều trị của nó tế bào T nó tăng xe đi em, chắc còn đúng rồi em. Cái thằng này nó là cái điểm nó thế nào? Số 4 đến 4. Vậy thằng này không thằng nào? Đâu cái chỗ pet ở đây.
Đang rất nhiều chỗ.
Đâu điểm.
Dạ, em kính chào các thầy cô, các anh chị ạ. Em là bác sĩ Giang ở bên phòng Minh 8. Thì em có xin ý kiến một chút xíu là nãy chuyên gia có bảo là không cần thiết phải xạ ấy ạ. Nhưng mà hôm trước thì có trao đổi với các bác sĩ bên đấy thì thực ra là cái việc phẫu thuật đấy thì là không biết là có lấy đúng những cái phần mà residual không ấy. Tại vì lúc qua bên em chụp phim lại thì ở chỗ cái phổi thì vẫn còn cái tổn thương ấy. Đấy thì em nhờ các thầy cô, các anh chị xin ý kiến chuyên gia thêm cho em về cái phần đấy. Thì thực chất lúc mổ ra thì không còn tế bào u sống, nhưng mà thực chất là lúc mà chụp phim lại thì vẫn còn các cái tổn thương ấy. Đấy thì em xin ý kiến thêm cái phần đấy.
Hà ơi, là chụp mà thấy còn tổn thương là chụp CT hay là chụp PET nhỉ Hà nhỉ? Giang nhỉ?
Dạ, chụp CT cô ạ. Hôm trước bên em có chụp CT thì vẫn còn cái tổn thương
trước khi mổ đi. Excuse me, Dr. Giang from the military hospital.
From the military hospital.
Yeah, it's a radiotherapist.
Okay.
Yeah. She's comment about that. They check the patient before coming last week, maybe.
Week.
The CT scan shows some lesion in the lung, and then they ask us about maybe our surgery operate the resect tumor is right or not, because they don't know about the residual tumor in this patient have or not, because the surgery is open, not on tumor, residual tumor.
Oh, yeah.
Then they think about maybe our surgeon cannot take.
Okay, so we don't know what they did. We don't know what the surgeon did. What was he taking? The mediastinal.
Yeah, because it's very difficult to take on.
Sure.
And then the radiologist in military hospital think about maybe this patient have a residual tumor.
Yes, but we had to look at the cells at the
CT scan.
At the CT.
Yeah.
Okay. We have to look at the CT before surgery and now and to have the date of surgery.
Yeah.
Can you do okay here on the left side somewhere, please?
Em bỏ cái okay rồi.
Thank you. What is this?
Tại sao lại giờ trò rồi? Đây là phim lúc nào đấy nhỉ? Cho phim em ơi, cho cái phim ban đầu nó có cái tổn thương trên MRI ấy, bạn nó có cái tổn thương xương cánh tay ở bên tay phải á. Phim MRI ấy.
Diagnosis is very large.
Em đọc ở trong cái áo đọc cái phổ quần
thế mới là chuyện thì thế nó mới đặt vào tổn thương xương mà.
Il y a un problème avec le son, the sound of the colleague. Silence, yes, but the sound of the radiologist we cannot hear very well. Oh, cervical.
Ông nó có cả ở
When was it?
Bởi vì là em đọc số.
So it's a wire.
Tình cờ nhìn thấy đâu. Tình cờ nhìn thấy, nhưng mà từ cái xương cánh tay mà mình ngọc vào cái đấy thì không thể không.
It was at the time of diagnosis. Ça flash.
Thì nó sẽ phim chụp ngực chứ. Xem ở trong cái phim chụp ngực cái Hùng ạ, lắp cấp ngang của ngực ấy.
Khi mà cái tổn thương thế này phải bảo đảo xương.
We cannot hear you.
Em bên mic có vấn đề em ạ, nghe chả ra được cái gì cả.
Phim thời gian nào chị? Phim cổng từ
thời điểm chẩn đoán.
Phim chẩn đoán em ạ. Em nhìn cái phim chẩn đoán MRI có cái phim nào MRI CT là phim chẩn đoán có cái xương cánh tay lúc nó dơ lên thì nhìn thấy cái đầu xương chụp cắt lớp em ạ.
Cắt lớp
Chắc là cắt lớp. Em xem thử có một cái tổn thương xương ở xương cánh tay.
Chụp riêng tay đâu.
Không phải chụp riêng tay đâu mà vô tình nó vào cái trường của phim ấy.
Thổ đến đây.
Bất ngờ. Không nghe trong sổ không hề có ghi gì bên tay thề.
Là đủ giai đoạn.
Không, từ đầu giờ từ cái này thề luôn. Đi lấy ra.
Lúc đầu là đánh giá sức khỏe của giai đoạn 4 đâu mà vẫn là giai đoạn 3. Đỡ 4
đầu đã là 4. Hoặc là không chép từ trong bệnh ra cho.
Cái mic ở đấy làm sao ấy Cường ơi? Chả nghe gì như ngặt mũi.
Đây nhá, có một cái chỗ hồng chụp. Nào. Chụp mà gửi sổ.
Đây có cái tổn xương đây đầu đấy, chính xác. Đấy có cái tổn xương đấy em. Đây là you see the lesson.
Yeah. They're very obviously a lytic lesion of the metastasis of the right colon. And it's very aggressive and malignant.
Mà bảo là di căn nó điển hình.
Cái tổn thương đấy Hùng ạ, tại vì là em zoom to ra được không? Ông cái xương ấy, xương cánh tay bên đấy, đúng rồi. Ok. Giang nhìn thấy cái xương này không? Cái xương cánh tay đầu trên của xương cánh tay có tổn thương đâu?
Mais j'ai pas vu les nodules dans la plaie.
Ah bah oui, au début, tu l'as pas vu. Nous non plus d'ailleurs.
C'est une grande lésion.
Tu as vu, il y a
It's one big lesion, it's not multiple small lesions.
Il n'y a pas de modification.
Ils disent jamais que les enfants sont douloureux.
Non, mais ça, c'est le même.
Quand ils présentent.
Non, je pense qu'on va.
À l'arrivée, tu vas au diagnostic.
So what is the question? Please, what is the question with this lesion?
I don't know the lesson is a maintenance or not.
Oh yes. All you have here all the pattern of aggressive lesion. It's lytic. It's not normal. It cannot be infectional. It's malignant lesion of the human. It's for sure.
Giang ơi, cái tổn thương này chắc là ác tính thôi, không phải là đảo xương hay gì đâu nhá.
Dạ vâng ạ.
Moi, 2024.
Ah, it's
En 2024, c'était...
Xua là giai đoạn 4 nhá. Is the bond lesion is a stage 4.
Yeah.
Yeah.
Tóm lại là cái ca này là stage 4 là không có gì nhầm nhá. Em ơi có cái phim nào gần đây không Hồng ơi?
Et on t'a pas montré le côté gauche. Le côté gauche, il y a que des bouts.
Oui.
Et les bouts de ça. Tu vas voir. Regarde les deux buts.
Je passe de là au rang.
Đó, em thấy con có cái dạng gentamicin.
Ça, c'est pas au début. Et ça, ta diagnostic.
Ils veulent voir comment ça évolue la ligne osseuse du bras.
Cái này không bắt được vào trường của cái này. Giang ơi, ở bên chỗ Giang chụp CT gần đây nhất thì có chụp được cái trường nó có phim có cái cánh tay không em?
Dạ đợt đấy lại không có các ạ. Không được chụp qua cái phần đấy hay
Standard X-ray.
Yeah. Em có phim X quang thường không? Cũng không vào trường đấy.
Yeah, not of the chest, of the heart.
You need to check.
Nào không có, mẹ không ghi cái tổn thương gì căn.
Không, hình như có đấy, có chỗ nào.
Yeah, but it's not it's a chest X-ray, it's not a
Đúng, có đấy, chắc là nó mở dưới vào cái chỗ nào rất kín đáo.
Ne faites pas dire.
You.
But it's not. Yeah, we can see it's still. Yeah, I don't think we can say it like that. It's not an X-ray performed to be able to study the humors. So it can still be a little bit heterogeneous. It doesn't mean that there is still lesion or anything. We have to see all the cortical, the periosteal, so I don't. This X-ray was not meant for the arm. You have to perform an X-ray of the arm to study the arm correctly, I think. If it's that important for stage 4.
Do you think we need take bone scan by cái gì nhỉ? Cái xạ hình xương là gì?
Or an X-ray, standard X-ray. Yeah. It can be very good. For bone lesion, it's very, very good to evaluate.
Yeah.
Or a CT scan.
Yeah.
But of the humerus.
You don't need to go back now to bone scan. The question now is, how is the bone of the humeral bone? Okay. When was it done?
27 mai 2025, et tu vois le 14 septembre, c'est là-dessus à côté sur la radio.
Okay.
Phim này bao giờ đấy em ơi? Tháng 5 chị, tháng 5.
Okay.
C'est le même bras, c'est le bon bras.
C'est le bras droit. Oui, tu vois la palette humérale, regarde en bas. Et la position anatomique.
Oui, mais tu sais, je sais pas s'ils ont une J, mais des fois la J, elle a les côtés, donc moi je me méfie. Parce que là, il n'y a vraiment rien.
Oui, le cœur n'est pas de ce côté-là.
C'est vrai
quoi?
Có nhưng mà không phải nặng lắm.
Okay, so on MRI it was almost normal.
Good. Good.
T1 is better to see the bone.
Okay. Good. And what was the question of the colleagues from the hospital, military hospital?
Yeah, is the step 4 is right or not? Now is right.
Yeah, it's right.
Yeah.
Yes.
And the second question is the dose of the radiotherapy.
Yeah.
And because they think about maybe the pathology now is maybe it's not right, because maybe is our surgeon cannot couldn't take
all the things.
All thing.
Yes, but if it was, we can say that if the surgeon, your surgeon, was taking a big amount of flesh to make the diagnosis of necrosis, it's good, you know. It's a pound of flesh, like in Shakespeare, the Venice, the Marchand de Venise.
Ah, c'est génial.
So I think it's nice to have to close the story now. From with your authority, you can close the story and say this patient is very likely to be cured now. And don't try to make stories, please.
Giang ơi, các bác ấy muốn thấy rằng là cái gì nhỉ, cái giải phẫu bệnh của bây giờ ấy là nó là hoại tử, nên là tế bào nó chết hết rồi, nên là các bác ấy muốn dừng ở đây và không điều trị, không xạ nữa và theo dõi. Nếu mà tái phát thì lúc ấy mới tính. Những em nào chắc em xin ý kiến lại về những nào.
Dạ vâng, thế thì chắc là em sẽ báo cáo lại với cả bên lãnh đạo bên em. Cái hội trần cũng đã quyết định như thế thì chắc là theo dõi cho cháu ạ. Còn các cái Cái biên bản phẫu thuật với cả các cái tổn thương thì cũng hơi lăn tăn một chút đấy, nhưng mà
em ơi, nếu mà em có thể em có thể, nếu mà em có cái phim mà có tổn thương của nó bây giờ vẫn còn ấy, thì mai thì em có thể cho nó copy cái đĩa xong rồi gửi lại cho bọn chị xem lại, đỡ phải chụp lần nữa nếu được.
Dạ vâng. Thế ngoài ra thì cái chỗ pet ấy ạ, chỗ pet đợt gần nhất thì cái chỗ tổn thương ở thành ngực thì nó vẫn còn cái răng uptake một tí ấy ạ. Đấy thì không biết cái chỗ đấy thì có giải quyết thế nào không, hay là mình chỉ dừng lại hay theo?
Thì bây giờ tại vì mình không có những cái bằng chứng phim ở đây, nên là nếu có được thì em cho nó copy cái đĩa đấy, hoặc là trên bọn chị đẩy đến phim để mai có thể hội thứ 5 hoặc thứ 6 bọn chị hội trần lại nhé.
Dạ vâng. Thế nếu mà bây giờ em quay cái video ở đây thì có được không ạ? Quay video, start
Em
video ở đây.
em share đi, bọn chị stop share.
Em quay bằng điện thoại.
Bằng điện thoại thì vấn đề là em phải share được trên máy là của em. Nó muốn share cái đấy chị. Em share đi.
Chị Trang ơi, chị ấn cho bên chị đấy làm co-host mới share được ạ?
Máy này từ máy này.
Có ba là tên sao? Có ba chấm
Không, máy này. Không. Đấy. Đâu.
Người ta đang soi được rồi mà.
Đang soi được rồi kìa. Em fix được cái điện thoại được không? Nhìn nó cứ quay trong trống. Rồi, ok. She want to show the CT scan now because she not confident to stop now. Nó không chạy nữa đâu em ạ.
Nó chạy đúng, nó đang lắc rồi.
Đấy rồi đấy.
C'est maintenant ça? Je sais pas.
Is it the same case?
Yes, same case.
Why don't we share that online?
Because she take telephone to make a video.
Yes, I think it's not the good way to share image.
The last CT.
It is the last CT which was done in
the CT
military
before,
hospital.
The CT now.
Yes, but the CT just before, I think it was already there, the nodule, no? It's after surgery, so maybe you have some...
Is it the CT for the preparation of your radiation?
Last week.
Last week?
Yeah. They prepare the CT scan before they have a consent to radiotherapy. Giang ơi, cái phần mềm của em không share được thẳng vào hệ thống này à?
I think we can have a
máy của em lại không lấy được, chỉ quay thế này được thôi ạ.
Yeah, maybe we can have a common response, which is that when was the surgery performed to make to find out that there was no live cells? When was it performed? Your surgery, when was it performed?
On September.
Of September?
Under 15 days. And you have the CT scan now. You have 15.
Non, ça fait un an, ça fait un mois. Un mois. Si c'était en septembre, ça fait un mois. We have to be very precise on what we say, because it depends on the date of surgery and the date of the recent CT scan. Ça, c'est pas un scan de pulmonaire, c'est un scan en position traitante.
Possiblement, j'en sais rien, mais si c'est la semaine dernière et qu'il voulait lire ça. Non.
The surgery was performed in September 2025.
So more than a month ago.
More than 1 month. More than 1 month.
So, and this CT scan was done last week. So 1 month later.
Em mới có phải phim để em chụp tận tuần trước không? Giang à?
Dạ, ngày 15 tháng 10 ạ. Cái phim này là ngày 15 tháng 10.
15 October.
15 of October. So it's probably 15 days after surgery or something like that. So it might be very close to surgery, too early. And what are they complaining about on this CT scan? What is the complaint? Is it something that is that may be post-surgery? Oui, c'est une ventilation.
Il n'y a pas que.
Non, et puis c'est pas des manières de regarder un scan. Je suis désolé. Hein. I'm very sorry, but it's not a way to compare scans. We cannot do that. I think it's not good to make a diagnosis or a discussion on scan that we see through a phone. We have to look at CT scan which are in the same plaques system so that we can compare things. And especially if the scan was done a while ago, shortly after surgery, I think we need to have more than 1 month between the surgical procedure and the scan that we compare to the scan previous to procedures. So I think we need to be very strict to go see in the same packs, look at in the same pack system to the pre-op and the post-op scan.
And if you have a surgical report,
and to have the
it would be
surgical
nice
report,
because
yes.
hopefully he had done mediastinal and lung by thoracostomy or thoracoscopy. You can do both. So you have to have the notice that he has done mediastinal and lung.
So we need to have the exact information.
The report.
Okay.
Or you can ask the pathologist, because on the pathologist report you have what he received. So you have a piece of lung, a piece of, and you have so you can, check that you have correct.
Because otherwise we have the risk of telling something which is wrong.
Yeah.
So we won't be able to tell anything if we do not have all the documents which are allowing us to discuss the case.
Because when you say mediastinal for a surgeon, you can have mediastinal. So you can, by thoracotomy, access to the both of organs. So it's not only mediastinal.
Oh, that's right. Oh, yes. Can you translate, please? Yeah, Naila will translate.
Yes.
She's very good in Vietnamese. She has Google Translate. Tu n'as pas trop de reflets?
Non, on va avoir tout dans le corps.
Commence par le
Alors, placement allongé sur le dos, poitrine rembourrée. Pratiquer une incision médiane sur le sternum à travers le lien médian.
Wow.
Utiliser une scie HM pour ouvrir le sternum verticalement de sa poitrine vers sa face interne. Arrêter le saignement de la plaie à l'aide de machin. Juste en dessous du sternum se trouve une masse de 2 x 4 x 6 correspondant au lobe droit du thymus et une masse de 1 x 2 x 4 correspondant au lobe droit. La dissection des deux vestiges inflammatoires de densité ferme entourant la veine illuminée, s'étendant envahissant le faisceau neuroblastoma, envahissant le parenchyme pulmonaire récent. Diagnostic tumeur du médiastin. La dissection a exposé la tumeur à ses fonds annexes. La tumeur inflammatoire était difficile à disséquer avec une incision pleurale bilatérale préservant le faisceau neurovasculaire crânien. Absence d'adénopathie médiastinale, absence d'épanchement pleural, résection d'une lésion invasive du segment pulmonaire S3, vérifier l'absence de lésions pulmonaires résiduelles, arrêter le saignement, laver la cavité pleurale des deux côtés, placer un drainage pleural bilatéral et après les nuages jaune-brun me font toujours soupirer. Donc je pense que
ça c'est
ça c'est au diagnostic.
Non, ça c'est
je vous jure. Il a demandé parce qu'il a
When was it? Peur de je sais pas quoi.
15 September.
15 September of this year.
Yeah.
So it's not a diagnosis.
It's now?
Yeah, it's 1 month ago.
Okay.
We checked it have a residual
So he
tumor.
has checked
Il a ouvert le thorax.
and the two tumors.
Yeah.
C'est le sternum.
Oui, il a trouvé le sternum, cardiaque, il a tout trouvé.
So it's a large surgery.
Yes.
It's an important surgery. So it's too early on the 15th of October to look at the post-op CT
And
scan.
we took a piece of the lung, so maybe that what we saw was the post-surgical of the lung.
Okay, so I think we stay calm. We do not irradiate.
Yeah. Okay.
At least.
Yeah.
At least for now. And redo the scan 1 month after the previous one. So let's say mid of November,
Yeah.
you redo the CT scan of the lungs and you don't irradiate before that.
Yeah.
Okay?
Yeah.
Are we done for 2 days?
Yeah. Gì nhỉ Giang ơi, tức là cái ca này thì vừa mới đã dịch lại cho các bác về cái biên bản phẫu thuật đi em, thì là bệnh nhân này đã được mổ cắt xương ức và lấy u tối đa ấy, thế nên là đã cắt u rất là nhiều rồi, nên là bác sĩ cũng nói rằng là cái tổn thương mà bây giờ giải phẫu bệnh mà không có tế bào u thì hoàn toàn có thể yên tâm là sẽ không xạ nữa em ạ.
Dạ vâng ạ. Thì em nhờ cô một chút xíu là mình ra cái chỗ phận mà tăng chuyển hóa ở cái vùng thành ngực phía trước ấy ạ, nó có tăng nhẹ một chút đấy ạ. Chỗ đấy thì nó lại không phẫu thuật, không gì. Giúp em chỗ cái phần đấy không đấy.
CT hay là PET?
Cái tổn thương thành ngực cái gì ạ? Tại vì là cái tổn thương thì các bác nghĩ rằng là đâu chỗ nào em nhỉ? Excuse me, Neila. They think about in the chest womb have a uptake. Yeah, this uptake is a one.
Il a un gros cœur.
And then
Yes, but it's hard to see if it's on the parietal or it's on the rib. Where is it?
Ở đâu? Ở đâu em? Thành ngực mà.
C'est la dernière.
Xương sườn mấy? Em ơi, xương sườn mấy em ơi? Ở thành đang từ xương sườn mấy?
Mais ils ont cassé les côtes en ouvrant. C'est avant la chirurgie. Je trouve que cet enfant a un gros cœur.
7 ạ.
Xương sườn 7. 7.
Ce foie
Là nó là vật cả cái phần tổ chức ở phía.
Có thể nó là vết mổ thì sao? Mổ ở thành ngực không? Nhưng mà nó có mổ nó mổ chi chứ có thể nó mổ một đường ngang như này rồi.
I'm sorry, it's not a good way to work.
Thôi chị ơi.
Ok.
Yeah, ok. Em ơi, cái này chắc là mình cứ theo dõi tiếp, bởi vì là các bác thấy nó cũng không quá là kiểu nặng ấy, nên là nên theo dõi em ạ. Tức là tóm lại là dừng điều trị ở đây và theo dõi sát mà.
Dạ vâng, thế em nhất trí. Thế thì em sẽ báo cáo lại chỉ huy khoa về cái buổi hội trần hôm nay ạ. Chắc là sẽ chuyển lại bên đấy nhờ các chị theo dõi cháu Vinh giúp em nhá.
Rồi chị cảm ơn nhá.
Dạ vâng ạ, em cảm ơn cả nhà. Dạ vâng ạ.
Ok, thank you em. Thank you so much for stop radiotherapy.
No radiotherapy. C'est une bonne nouvelle pour la famille.
Yes.
Thank you so much.
I think you should probably look at the myocardial function. Because this patient received a lot of anthracyclines, and he has a big heart on the CT scan.
Yeah. Okay. Thank you so much.
You are welcome.
Long day.
We are very happy that the day is finished, and we are eager to see you maybe tomorrow in K Hospital.
Yes.
Or at least back on Wednesday here.
Yes.
And Wednesday we will start with the surgeons at 10. Maybe something before, we will see. Okay?
Yeah.
Wednesday.
Wednesday, 10 o'clock.
10 o'clock,
yeah.
But should we come before? 10?
No, we have a continued program,
Okay.
but we change only the 10 o'clock. We have a strict the lecture.
Okay. So we can go. We can do the. At what time do we start on Wednesday?
9 o'clock. We keep the program.
Yes, we
but
keep
in the
And
10
10?
and maybe have as a lecture and
Okay.
then we switch the from
Yes,
the
we switch to
Wednesday.
the surgery.
Yeah.
Okay.
Yeah. It's okay.
On viendra après.
In Wednesday, we need to go to not here in the go to the third floor. We take the meeting room in the third floor.
The third floor.
Yeah,
Yes.
third floor.
Okay.
In the telehealth meeting, I mean to take you to show in the floor.
So,
because it's a big room than this room, and then take more surgery from other hospitals.
Okay.
Yeah.
So you will tell us.
Yeah.
Well, we have to go to third floor.
Yeah.
Okay.
Okay.
It's the floor of the direction.
Yeah. Thank you so much. Yeah.
Thank you.
And remind in the Thursday 6 p.m. and dinner with the
Oh yes, on Thursday.
Yeah, Thursday. Thank you so much. And Dr. Hoa from Việt Hospital want to invite your group have a dinner.
We have to.
You see the shop near would like to find the time is a fit for you.
Okay, good. Good.
Yeah, on Wednesday.
On Wednesday morning.
Yeah.
Anh em sẽ bỏ đi ngay đi anh. Anh bỏ đi ngay 2B.
Đấy, tay bỏ đi đâu?
Chị em mình nhà mấy đĩa đâu.
Chả biết dọn.
Dọn đi ra rác chứ đi đâu.
Cứ quá.
Thế anh em đi về nhanh thế.
Dọn đi những chỗ nào.
Bát đĩa để ra ngoài.
Lô, rồi. Chị bảo này tối nay thì
còn nhiều lắm, phải giữ lại.
có nhiều việc không kịp nhớ ra, bây giờ thì có thể không thì mời các bác luôn, còn không thì tối thứ 6 thì phải ăn sớm để các bác ra sân bay, có một số bác ra sân bay luôn. Ok. Tối thứ 6 nhá, tối thứ 6 ăn sớm nhá. Chị bạn đã giờ mình xong rồi chị đó quên đã thế nhá, chị cảm ơn. Maybe it's a Friday. We have a dinner after that go to the airport.
We're at least the three of us. At least Sarah
and then you will have a dinner maybe earlier, maybe 5 or 6 for you. And then you go to
we have to be in the airport at 8 o'clock. 8:30.
Maybe
Yes. Dr. Lan told me that she would get up. She will pick us up at I don't know how.
we have a video.
Okay.
Then maybe
Cho mấy không có chị Lan đây không đấy. Chị đấy, em mới bảo là bây giờ cái đống này Hạnh những đâu mất rồi, còn đậu em ra được, em sao em đang nghĩ tìm với Hạnh. Cái này bây giờ mình làm sao mà mình hết được. Mình dọn nó cũng không đúng được ấy. Thì vứt cái này nữa nhá. Còn những cái này thì chắc là bỏ đi thì phí, mà để lại thì nó thật là đến mai thì
mang xuống chứ không để lại mai ở đây đâu.
Okay. 5 ladies are free on Wednesday. I am the only one with time to go to the HMU. I know the Italian University.
It's a Wednesday, it's okay.
The 5 is okay.
I'm sorry.
I have no problem.
Yeah, I do that come with the
Anh ơi, cắt cái này thế nào anh?
Chị vâng ạ, nếu thứ tư thì chỉ có bác Mỹ Sông với cả cô An. Vâng ạ, là bận thôi, còn 5 người còn lại thì vẫn không free, thì em có muốn mời vào thứ tư không? Đấy à, tóm lại là 6 thì tổng số hơn. Ok. Wednesday, then on Friday. Yeah, Friday. Friday.
We have the. We are going to fly Friday. We have shopping. We have with Sarah and
yeah.
So they can be the form of them on Friday. That was the back. Okay. If it's somebody, let's see, because I because look down one to see and the so maybe we can have a lunch someday, Wednesday or Thursday, or Friday.
Em ơi, từ tối 6 có bác ấy ra sân bay hay là lớp học kết thúc vào buổi trưa thì anh mời ăn trưa không? Thì để các bác ăn trưa xong rồi các bác ấy đi xong. Cường nó sẽ lên nó tắt. Để anh. Cường lên tắt.
Cường nó tắt cái gì?
Chìa khóa để đây
tức là Cường có biết gì? Thì đấy, cái con chị em mình bê cái đống này về cái gì? Cái này thì để đây. Mai nó vẫn thế.
Ai đấy?
Thì không thì thôi đi. Cái đống ấy vứt đi.
Đống nào?
Cái đống gọi là dưa hấu đấy, mẹ não em bắt đầu đấy rồi đấy, em vào này.
Em ơi, em nào dẫn cho chị hai xuống cái. Ra. Đi còn nó xe không? Có gọi xe không? Mình đặt xe lớn đi.
Không, bây giờ đông người đây không thể nữa.
Không phải để chị gọi xe, hỏi tổ xe có xe đón không? Một bạn là đưa xuống đi. Để ra không có thú. Mình thì gọi chúng nó đi, mình cứ làm như là giống chị đấy.
Chị đi, em dẫn dọn cho vậy.
Này giống chị đấy, làm nghe không?
Để em vứt cái đống đi cho. Anh mới thật đấy, để lại cái bổi thôi, còn ăn được mấy cái để lương.
Em dẫn khách đi không? Có tổ xe. Cổng 2. Cổng 2.
Cái đĩa là của ai?
Cái tổ của tin. Riêng có xe để đỡ cái chuyên gia về không hay để gọi taxi? Tại vì đi ngay chỗ Thảo Sơn thôi, còn không thì để đi bộ nó hết mưa chưa, tại vì đang ngồi trong trường này. Dạ, nhìn xem có không, nếu không mưa thì cho họ đi bộ vậy. Kiểm tra lại xe nhé, nếu mà có xe thì báo, còn không tôi để nó cố tình mà đi bộ.
Cái đống này
để nhá.
Bây giờ mình
7 người. Để nhá.
Dọn đâu cái đâu? Để em.
Mày từ từ để tao tí cái.
Nó chạy nhanh vãi.
Chị hỏi em luôn đấy. Tóm này là em chờ xem tổ xe rồi ra có xe không vẫn tổ về. Tổ cái Bảo Sơn á. Gần Bảo Sơn nhớ biết ở đâu đấy?
Bảo Sơn ngay đây mà.
Mày đùa tao đấy. Không biết gì đây.
Chưa biết rồi nhưng mà em sẽ đi cho anh mà. Đừng kệ chị hai anh bây giờ mày lo lại em. Mày lo rồi giải quyết cái đống này với tao này. Bây giờ cái đống đĩa này bây giờ làm nào chị?
Đĩa bây giờ mày lấy cái túi ni lông.
Em nói thật em nói thật cái đống hoa quả đấy bỏ đi, dám để không ai ăn đâu mà bây giờ để đến mai.
Người ta ăn thì ăn, còn không thì